Before we start, this meeting will have French and English interpretation. And today I'm pleased to share that we have a French panelist, so the English speakers will need to select the globe in English to hear interpretation. We also want to welcome our French speaker participants. So let me invite Clara Annabelle to give instructions on how to select translation to French.
Bonjour à tous et bienvenue à la réunion annuelle de la communauté de pratique sur l'hémorragie du postpartum qui se déroule aujourd'hui et demain. Donc, je suis Clara, conseillère technique en santé maternelle et néonatale. Je fais partie aussi de la communauté de pratique. Pour les francophones qui nous ont rejoints, je vais vous demander d'accéder à la barre d'outils de Zoom, de cliquer sur le globe, de sélectionner le français et de désactiver la langue originale pour bénéficier pleinement de l'interprétation en français. Sur ce, bonne écoute et bonne participation. Merci. Over, Sherry.
Thank you, Clara. So now that we have translation sorted, good morning, good afternoon, good evening, and welcome to the 5th annual virtual Postpartum Hemorrhage Community of Practice annual meeting. That's a mouthful. My name is Sherry Evans, and I'm the current chair of the steering committee of the Community of Practice. As a midwife and a doctor of public health focused on maternal survival, it is my great pleasure to welcome each of you. The past year has been a busy one for moving the needle on postpartum hemorrhage. It was just over a year ago that the roadmap to combat postpartum hemorrhage was launched and was followed by 2 new WHO recommendations on early detection and first response treatment bundle. So the steering committee chose accelerating that roadmap to be this year's theme. Next slide. Our objectives for the meeting are on the slide. We want to review the postpartum hemorrhage roadmap's vision, objectives, and progress. We want to discuss interprofessional collaboration to address postpartum hemorrhage. We want to elevate country experiences in implementing elements of the roadmap and discuss refractory postpartum hemorrhage and management. Next slide. So here's our agenda for today. We hope that you will stay for the entire time, but you can see the time slots if you need to jump in and out. We are going to dive into these important topics over the next 2 days, but I want to acknowledge that we had an election in the US yesterday, and elections anywhere can bring uncertainty and anxiety. So we ask for some patience for US-based colleagues or others who might be feeling the weight of these events. Next slide, please. So just a bit of housekeeping. Please take a moment now, if you wish, to jump into the chat and introduce yourselves. We're going to be closing the chat box when we get started with our formal presentations, but now's your opportunity to say hi. For questions to speakers, please use the Q&A box. For those who are interested, we will be sharing links to presentations after the meeting. And speakers, just to know, your moderator will come on camera a minute or so before your time is up. So when you see them, please wrap up your presentation. And again, the interpretation rooms, English and French, please be sure that you're sorted so you can hear both the English and the French speakers. Next slide. Finally, before we launch into our opening session, I'd like to invite some brief remarks. I'll start with a welcome from Deborah Armbruster. Deborah is a nurse midwife with a master's in public health and a fellow of the American College of Nurse Midwives. She's over 30 years of experience in safe motherhood and reproductive health programs in over 25 countries. Ms. Armbruster is currently with USAID as a senior maternal newborn health advisor and came to USAID from PATH, where she was the director of the Prevention of Postpartum Hemorrhage Initiative, or the POPPY project. Welcome, Debbie.
Thanks so much, Sherry. And I am just here to give everyone a big welcome and thank you for coming, and let everyone know that USAID is very pleased to support and has been supporting the PPH-COP over many years now. And we consider it a really important place for dialogue, for sharing research, etc. I don't want to spend a lot of time here, but we do want to say that we're really pleased to be also supporting the scale up of the PPH roadmap, really trying to work to scale up also the results from the emotive trial with that PPH bundle and its implementation strategies, So we hope you all are doing the same. And lastly, I just want to give a huge thank you to the steering committee who actually put this whole meeting together and has been working through the years with lots of great members and taking time out of their busy schedules. And lastly, huge thanks to Sherry and her team from JPIGO and the Momentum Country and Global Leadership team. They do an excellent job. And with that, I really look forward to the meeting and to learning from all of you. Back to you, Sherry.
Thanks, Debbie, for your continued passion and support. Next slide. Now I'd like to invite Suzanne Stalls to give her remarks. Suzanne has worked throughout the world during the past 25 years in the fields of maternal, newborn, and reproductive health. Ms. Stalls is currently director of the Maternal Newborn Health Team for Momentum Country and Global Leadership, a global technical leadership award funded by USAID in a consortium directed by JPIGO. In her role, she contributes to global technical leadership and learning, supports the policy dialogue required for achievement of global health goals through MNCH, family planning and reproductive health initiatives, strategies, frameworks, guidelines, and action plans that have been endorsed worldwide. Welcome, Suzanne. Suzanne, are you able to come off mute?
I am. I'm. All of the introductions are occluding my ability to also make sure that I am able to show my video. So I think in the interest of just moving things along, I am not going to be concerned about coming off my muted video and then just go ahead and give these remarks, but very apologies for that. I'm working from a number of different screens, as I'm sure many of us have done multiple times, but thank you so much, Sherry. And on behalf of USAID's Momentum Country and Global Leadership, I'd like to thank everyone who's taken the time to join us for this annual meeting. It's wonderful to be with you all. We come together at a really critical and exciting moment for the global movement to prevent postpartum hemorrhage. Postpartum hemorrhage, as we well know, is the leading cause of maternal mortality and has been a significant focus of maternal health in the past few decades. Even when women survive postpartum hemorrhage, it can cause lasting health issues. But more than ever, there's progress. More women are giving birth in facilities. Methods of PPH prevention and treatment are improving. There is more investment in data collection to track key indicators. And collectively, communities like this one are continuing to learn and share how to improve the quality of care. Last year, WHO hosted a postpartum hemorrhage summit that launched a call to action that resulted in the new roadmap to combat postpartum hemorrhage between 2023 and 2030. This consensus-based document will shape the future of how we address PPH globally. More than a year after its release, we're excited that the first day of this meeting will be an important platform to continue conversations, to accelerate progress on that roadmap, and to learn from country examples. And then tomorrow, as Sherry noted earlier, our expert guest will take a deep dive on a critical issue for the community, how to look at refractory bleeding, what might be a structured response, and what are the available resources to providers. So we have speakers from WHO, FIGO, ICM, and many countries sharing their barriers, their challenges, their successes. Our global movement is growing. We have more than, it was originally 600, and I think we're greater than that now registered for this meeting. I'm personally so proud to be part of a community like this one that's committed to connecting, sharing, learning, all to save the lives of women and children. Each of you is an important part of this event and of the ongoing efforts of this community to work with country partners to align the maternal, newborn, and child health community on the latest PPH strategies and to mobilize action and accelerate progress. I encourage all of you to openly share your knowledge, your expertise, and your experiences throughout this meeting for a rich learning experience for all. By gathering today, we ensure our work to address PPH goes beyond our individual facilities, institutes, or organizations. And who knows where the seeds that we plant today will grow around the world tomorrow. I want to extend a warm thank you to all of our speakers, moderators, panelists, and to event organizers for their efforts in planning this meeting over the past few months. It is definitely a significant effort. But when mothers and newborns thrive, families do as well, communities do as well, and ultimately the countries that we live in. Again, I thank you for your dedication, your insights, and your participation in this annual meeting. I'll turn it back over to Sherry now. And thanks so much and welcome.
Thanks, as always, Suzanne. Very much appreciate your remarks and Deborah's as well. Next slide. Without further ado, I'd like to introduce our first session to set the stage for our meeting today with an update on the PPH roadmap. It is my honor to introduce Dr. Jonas Gallos. Dr. Gallos is a medical officer at the UNDP, UNFPA, UNICEF, WHO, World Bank Special Program of Research, Development and Research Training in Human Reproduction, or HRP, within the Department of Sexual and Reproductive Health and Research at WHO. Dr. Gallos provides scientific and technical leadership, coordination, and managerial support for implementation of large-scale research projects and guideline development in maternal and perinatal health. He currently leads WHO's work in intrapartum care, including preterm birth and, of course, postpartum hemorrhage. Welcome, Dr. Gallos.
Very much for the kind introduction, and also thank you for the kind invitation to your annual meeting of the Community of Practice on Postpartum Hemorrhage. I'd like to say first that WHO considers this community as critical to improving clinical practices and the implementation of WHO recommendations as they relate to postpartum hemorrhage. To the next slide. I'll be giving an update on the postpartum hemorrhage roadmap and the progress across the 4 strategic areas since it was launched just over a year ago. We'll be highlighting key achievements and challenges to date and spotlight potential areas for coordination and collaboration. Go to the next one, please. So the photo here is from the Postpartum Hemorrhage Summit in Dubai in March 23. This was a unique initiative that brought together for the first time 140 stakeholders working on postpartum hemorrhage, and together they participated in the summit that was focusing on that condition and included representative of 20 ministries of health of the most affected countries. This was where the roadmap was first drafted collaboratively before it was published in October the same year. Next slide. And why did we feel the need to do things differently this time? This is because the progress we have been seeing year after year on reducing maternal mortality has stopped. So in the latest maternal mortality estimates coming from WHO, there has been a flat line for maternal mortality, and flat in this instance means death. And in fact, if we don't do something different, 1 million more women will die unnecessarily until 2030. Next slide. And this is the roadmap publication. And here we're describing how we can combat postpartum hemorrhage from now until 2030 if we want to see progress on postpartum hemorrhage and maternal mortality. Next slide. So the roadmap is split across goals and milestones across 4 strategic areas. And the 4 strategic areas include research, norms and standards, implementation, and advocacy. Some of the key milestones include funding the research priorities identified in the roadmap, publishing recommendations on the back of these research priorities that are actioning the impactful evidence that come out of them, and then consolidating all recommendations of postpartum hemorrhage in one single guideline with user-friendly implementation tools. So this is just an example of some of the milestones that are described in the roadmap of how we can make progress on postpartum hemorrhage. So if you go to the next slide. I'd like to start with the research strategic area. Next, please. So for the research strategic area, there were 15 questions prioritized across innovation, implementation, and cross-cutting research. Some of these questions had already received funding and they were ongoing, or at least there was a clear research plan to address the question. But nevertheless, several still remain unfunded and unanswered. Next slide. And to encourage researchers and funders to invest their resources in addressing the research priorities, WHO is designing target policy profiles, and those outline the type of research that can robustly address each research question and likely to lead to a new impactful policy. Next one, please. So these are now drafted, and we hope to be able to share them with researchers and funders soon so they can initiate progress on the remaining unanswered questions. Next one. As an example, one of the research priorities that published impactful results was on the early detection and treatment of postpartum hemorrhage. WHO was able to respond to that research priority in record time of around 5 months to publish recommendations on the back of that impactful evidence, and specifically on the objective quantification of blood loss, which is now recommended for all women giving birth, and the bundle approach to treatment. Next slide. So moving on to the norms and standard strategic area, if you go to the next one. So for this, one of the key goals was to produce one single consolidated guideline on postpartum hemorrhage. And this is now being implemented together with FIGO and ICM. So this work is ongoing. There have already been 2 online guideline development group meetings, and there's an in-person last guideline development group meeting planned for December this year, and we're aiming for publication of the final document by Q1 25. And the idea of this new guideline is that it will be comprehensive. It will contain all PPH related recommendations, and that will put an end to our current fragmentation of PPH recommendations from WHO that span across several documents. So we're hoping that it will be much more user-friendly for health workers. FIGO and ICM has signed a memorandum of understanding for this guideline work and derivative implementation materials, and for dissemination and in-country adoption of the new guideline. Next slide. And besides the new guideline, there are also additional materials, derivative materials, coming soon to support implementation of the new guideline. And that includes training materials in collaboration with JPIGO and Lateral Foundation, a WHO Academy online course, and implementation toolkit to support countries in their implementation efforts. Next slide. So next one is the implementation strategic area, and that's considered perhaps the most challenging, but also the one with more potential for impact. Next slide. And from WHO perspective, we hope that we would have been able to give a good boost to implementation with a new guideline and all the implementation tools and materials that are being planned. But WHO cannot do this alone. So many of our partners have already sprung into action and implementing the roadmap, and were able to give us information about their initiatives that are currently implementing to respond to the roadmap related priorities. There are probably too many to cover here, but I'll just mention a couple of examples. If you go to the next one, please. So an encouraging example was the investments from UNITAID of $68 million to address research priorities identified in the roadmap. And UNITAID is also partnering with UNFPA on country adoption of key commodities, regional advocacy, and industry engagement to enhance Africa regional manufacturing. Next one. UNFPA is also making substantial contributions towards addressing the roadmap priorities. And if you go to the next one. And one example is the Match Fund that we consider very important because it supports governments to increase investments into PPH commodities and also incentivize the switch to quality assured products. And that further supports introduction, for example, of heat-stable carbetocin and tranexamic acid into their health systems. Next one. I'd like also to mention that USAID and FCTO have also recently launched a partnership among other initiatives, for quality assured medicines for maternal and newborn health that also strengthens regulatory and data systems. Next one. Finally, WHO is also hoping to assist with in-country implementation, and to help with that, we also translated the roadmap in all 6 UN languages. Next one. And last one is the advocacy strategic area. So if you go to the next slide, where we think definitely more work is required for effective advocacy. I think your group may be critical, and good collaboration and coordination among partners to boost that strategic area will be very important. And compared to other health areas that have seen huge progress like malaria, HIV, PPH seems to be lacking the leadership and funding consolidations that they have. So perhaps a unified global branding strategy is required that can include local advocacy frameworks, and that can help drive and maintain attention and funding on postpartum hemorrhage. Thank you very much. Next slide, please. And that's all from me. Thank you.
Thanks so much, Yannis. Now we want to open it up for questions. So everyone, please put any questions you have in the Q&A. Before I go and have a peek at that, I have a question. So you bring up the point that we now have fragmented guidelines because WHO is using this living guideline approach, and now it's time to bring them all together in one consolidated package. Once this is launched, is the intention that WHO will go back to a living guideline approach? So if there's new evidence, or do we wait another 5 years for another consolidated package?
That's a very good question. So I think in the first instance, we would like to consolidate it and see them all sitting under one roof. And that's our primary goal. Once that has been achieved, we're hoping as our next step is perhaps to make this available as a web index guideline. So it will be sort of online guideline, and again, it will be much more user-friendly. Perhaps if you're familiar with WHO documents now, that perhaps for one recommendation, there may be a document of 50 or 60 pages. As a web index guideline, someone who is very interested on specific recommendations can only look at the recommendation text, and if you're interested in the remarks, you can open those, but you don't need to be accessing, the whole sort of methodology information. So we're hoping a web index format may be a little bit more user-friendly for accessing the actual recommendations. And WHO now is transitioning a lot of its guidelines into that sort of online environment called Magic App. So some of them are already available online in that format, and we're hoping this to be our first guideline available in that sort of online environment. And once this is available in that environment, then our living approach can be perhaps easier to implement, because we can replace one recommendation per recommendation when there is new impactful evidence, but you can still review all our recommendations as a whole, not across several documents. Over.
Okay, thank you for that. So we have a question about the toolkit. So I think there's a lot of interest in that. What do you feel that, what do you anticipate the components of the toolkit will be?
So the toolkit, we're hoping it's a guide of how to get started. Once you have a guideline that perhaps we already know will contain around 40 to 50 recommendations. And if you're sitting in the Ministry of Health thinking about what to do with these 50 recommendations, is how to get started. How to take an international guideline and adopt it in country, what adaptations you will require to do to cater for your population, and how to approach these adaptations before you create your own national guideline. And once you are also in that step, how do you then want to move on to a step-down training plan? Because if there are some new recommendations that people are not implementing yet, then you need to make a plan about how to train providers. You need to have a plan of how you're going to be accessing the new commodities if some of those are recommended. So, how do you do all these implementation steps so we can help, the implementation in country much more than before?
Thanks for that, Jonas. So we have a question from Kenya. How do you anticipate to do advocacy? So that's actually probably a whole annual meeting in and of itself. But yeah, what are the chief components of advocacy? As you say, it's hard to know where to start when you have a large, consolidated guideline that lands on your desk.
I think advocacy is perhaps the most underutilized strategy among them all. It seems that we do have some clear plan of, we have a guideline, we know how to assess the evidence and come up with recommendations. And then I think the implementation is people are putting a lot of focus on. But for succeeding with implementation, you actually need advocacy to go hand by hand. We seem not to have a clear strategy yet of how we want to use advocacy to increase our implementation success. And often we see that a lot of the partners that don't come together to sort of build a strategy together. They may see partners building their own sort of advocacy strategies, but they don't come together as a coherent whole. So from our part, we're trying to catalyze, discussions and partnership between some of those organizations, so that we can have a common strategy of how we want to be approaching advocacy. And we're likely to be much more successful, not just for raising funding, but also with our implementation efforts if we're better coordinated.
Okay, thank you for that answer. There is a question regarding the challenge of commodity access and quality medications that the roadmap addresses. Can you share any specifics about what WHO's vision is for continuing to work in this really challenging area?
I think the implementation tool may be a little bit more helpful in how to do a bit of forecasting about commodities. So WHO expertise is not necessarily on commodity procurement, but what we can do at least is advise on when it comes to implement a new recommendations that involves a new commodity. At least we can work with partners like UNFPA or UNICEF just to understand what will be the commodity requirements in country. How can we strengthen some of the regulatory approvals that they may be required or update national essential medicines list. So at least these commodities are made available in country and eventually they can reach the bedside. So part of this implementation toolkit is to provide some information around that and some guidance, but that will also involve other partners besides WHO.
Okay, thank you. And I think we ran into a little bit of a Zoom challenge that there are actually speakers who have questions and they can't type in the Q&A. So I was getting a sidebar message. What do you see as the largest barrier to implement the changes as leading the guideline development group and the process? You kind of have a lens to what's coming down the pipeline. And I know you can't share any of that, but what do you see the largest barrier to the changes that are coming?
Perhaps something that occurred to us at the summit was, as WHO, we'll be producing recommendations for decades. But so many of the countries that they have a very high burden of postpartum hemorrhage, they don't yet have a national guideline. And I think how to support the countries in terms of getting their own national guideline, in terms of reviewing the evidence, deciding, what adaptations they may require, and eventually adopt these recommendations as they see fit. It's a huge milestone. I think if we can get started with this, the high burden countries have their own national PPH guideline and PPH plans for implementation. That would be a great achievement. And from WHO perspective, we would definitely want to support them all the way. And some of these materials that are being produced for postpartum hemorrhage for the first time, they are meant to respond to that need.
Okay, thank you for that. And actually, we just had a little bit of a flood into the Q&A, so I'll start. This is also from Kenya, but an anonymous participant. So Kenya already has adopted the PPH recommendation in their key documents. What are some of the research areas that could be helpful to generate evidence for programming? That's a great question.
I think it says Caroline Kinsella would like to answer this question.
Caroline?
Oh, sorry, no, for Giannis.
So I think that question went. So the research priorities, they have been published. So I think for implementation, some of the things that are lacking is to understand a little bit better the barriers and enablers to implementation. And again, perhaps that can be informing also what tools we select to develop or prioritize for the toolkit. I think my colleague Caitlin Williams can also speak more to the implementation toolkit and what will be the research requirements for these tools. Caitlin, are you able to add to that, please?
Sure. Thanks, Giannis. And hi, everyone. Nice to see you all today, and thank you for being here. I think in terms of the implementation toolkit, one of the things that we really are struggling with, I think, as a postpartum hemorrhage community is that we have these evidence-based guidelines. We kind of know what to do, but we've struggled to get it into practice. And I think to the point was brought up with this comment that you can have strong leadership at national level, you can have adoption of all of the guidelines, but figuring out how to actually get to that next step so that we can get all of these evidence-based interventions, the last mile is very challenging. And we understand that often there are larger system level bottlenecks and constraints that prevent implementation, right? You can have a guideline that recommends use of a certain medication, but if that medication is not available in a facility at the moment that a woman is having a postpartum hemorrhage, it doesn't do you much good to know that the drug has been approved and that you know how to use it. So what we're hoping with the implementation toolkit is that we'll be able to leverage some of the best insights from behavior change theory, from implementation science, about how we actually overcome those barriers and get interventions available to the people who need them so they can be put into practice. So I do think there are some opportunities for implementation research that will be specific to postpartum hemorrhage in responding to some of these questions. And at the same time, we probably know enough to start giving us some direction about what we need to do. So without getting too much into the details about the specific tools of the implementation toolkit, because they're still under development, I think there's some real opportunities here, and we're very excited to be debuting the toolkit alongside the guidelines early next year. Hope that helps.
Thanks so much, Caitlin. I see another anonymous. Thank you for updating us about the roadmap. How is the roadmap milestones aligned to the SDG targets and any timeline?
Thanks. It was another one before that about the quality of medicines. I can answer both. So for the quality of medicines, in the roadmap, there were two solutions proposed. That one, we should be exploring perhaps a global procurement mechanism, whereby the countries they can still maintain their budgets that are being allocated for maternal health commodities. We don't want those to be deprioritized or directed elsewhere, and then it will be very difficult to redirect them to maternal health commodities in the future. But we would like to be able to incentivize them towards quality assured commodities. And UNFPA's initiative is really responding exactly to that priority. But besides the global procurement, we also need to be strengthening their own sort of regulatory systems of, for registration in country, especially for new commodities, inclusion in the essential medicines list, so they can be made available and used in countries. So we're hoping this will go a long way for addressing some of the quality concerns. In terms of the milestones and how they align to the SDG targets, we're hoping that maternal mortality reduction can happen as a back of the roadmap success. For the time being, we are completely off target of our SDG target, and we're hoping that can get us back on track. There will be a lot of hard work until 2030, but I think we just need to get started. And PPH is definitely being the biggest killer of mothers, our top priority.
Thanks for that, Giannis. There was a question, or actually a statement, and a question. So postpartum hemorrhage greatly negatively impacts on maternal health. How can the wonderful guidelines, how can we get rid of the old practices? And Giannis, I think that was something we experienced during the emotive trial, getting providers to change from what they have been doing in the past into something new that is evidence-based and is a WHO recommendation. What do you think is the best path forward to get providers to move to those new practices?
Yes, so none of this is easy. Any new practice, bringing into the clinical practice is an agonizing process. And I think from our perspective, we don't want to be stopping just at saying, what is the new practice that needs to be implemented, but also going a little bit deeper of how, some of these practices need to be implemented. And I think some of the very strong behavioral change strategies is perhaps auditing some of the key indicators, let's say, of, what you need to change. So if you want to be changing a medicine, let's say, what occurs to me is perhaps, let's say, the bundle for the first response treatment. You need to measure this indicator. Are you giving oxytocin, together with 2XA to all women of postpartum hemorrhage? That's something that was not happening previously, even though WHO had a recommendation since 2017. When you come up to the clinical practice, you could see that people were using tranexamic acid not as a first-line treatment together with oxytocin, but mostly as a second line, third line, and so on. So if you do have an indicator that you're measuring, whoever had a postpartum hemorrhage, are they getting both medicines at the same time? And as long as you're able to give the feedback that the providers, you should be able to gradually change these practices. So these are some of the strategies that we want to be proposing, especially for some of the recommendations that they haven't embedded in practice yet.
Okay, yeah, that is a tough one. So this is actually a really good question, and I do hear this on occasion during my travels. Does a country need to rely on specific evidence based on its own context, or could evidence from other countries be considered sufficient for the purpose for drugs, devices to be added to the national guidelines? What are your thoughts on that?
Sorry, can you repeat that, please?
Sure. Yeah. The question is, do individual countries need to basically generate specific evidence based on their own context, or can they rely on evidence from other countries in order to make changes to their guidelines?
That's something we have been coming across for a long time, and perhaps there's a little bit of a differences in opinions here between WHOs and some of what ministries may think. So when a WHO makes a recommendation, and depending on the kind of recommendation, so if it's a global recommendations means, so let's say objectively quantifying blood loss, it's now a global recommendation for all births. It's not a context-specific recommendation. We're not saying only in the circumstance of the women having, this characteristic or the other. We're saying all women giving birth, you need to objectively quantify blood loss. What we also want to be avoiding is a situation where a ministry decides not to implement this recommendation because it requires some further research. We think this is perhaps counterproductive at that point, because it may, you may, quite a few years away before implementing this recommendation. And the Guideline Development Group, when they developed that recommendation, they were having in mind that women can benefit across all countries right now. And what we don't want is, women not benefiting from it for a few years, waiting for additional research evidence. If there is a difference in recommendation, so in the context of a country having this problem or the other problem, then yes, then the countries may still need to understand, their context better to understand if that recommendation applies to them. But for the global recommendations, we wouldn't want any further research.
Okay, thanks, Giannis. And there's a question that's written in French, which I do not speak. So Giannis, if you or Caitlin speak French, if not, we can invite Clara to read the question.
Caitlin is fluent in French. Caitlin, over to you.
Yeah, Caitlin, can you see the question?
I think so. Is this the question from Florent?
Yes.
Yes, it would be helpful to know. So the question is asking, is this product or medicine known by our countries, above all the ministries of health? And I suppose with this question, I don't know if there's reference to a specific product or medication here that you're asking about, Florent, but I do think in general, that this is an open question with some of the interventions that can be used for PPH. Certainly, WHO can recommend an intervention, but if country ministries aren't familiar with that intervention, that obviously ministries have many competing priorities. PPH is an important priority, but it's not the only one that a minister is charged with and that a ministry is charged with. And so I do think that, harkening back to some of the earlier questions about advocacy, this actually is a great place for there to be advocacy work at the country level, is to ensure that ministries of health and other important policymakers and decision makers are aware that we have this full range of interventions, running from prevention through first response treatment for PPH to treatment for refractory PPH, right? There are a number of different interventions that are recommended, and we have evidence that the bundle for first response treatment is extraordinarily effective. So we need to make sure that ministries know that these interventions exist, that they're proven, that they're recommended by WHO, and that they can be adopted and implemented in country. So I think that's a very tangible advocacy step that we can take. And thank you to Florent for raising that question.
Thanks so much, Caitlin. And I think that exact question popped up when Giannis was speaking about TXA and how old that guideline really was at this point. And so I think, we are finding in many countries that maybe it's in the country, but it's not approved for use in obstetrics, for example. So yeah, thanks so much. Now, I will say we're getting close to needing to wrap up, and there's a bunch of different questions that have popped up from commodities and supplies and people offering tool kits that they have. There's a question about near miss, and then there's also a question about HMIS. So I would ask you, Giannis, is there any one or two of those that you want to jump into before we close?
Okay, I can selectively answer then.
Yeah, please.
In terms of the materials being available in other languages, then it's a yes. I think the first version will be in English, and then we'll aim to translate them to other UN languages as soon as possible. Catherine Taylor was saying that there is a toolkit developed for a project, and it would be great if we can preview this for the development of our toolkit as well, for the smiles from others. There's still a lot of questions. I think that's all for me. Caitlin, anything else you can answer to?
I would love to actually lift up Geeta's question about near miss and about women who survive PPH. I think, we talk a lot about maternal mortality because maternal mortality is an important indicator. Obviously, losing a mother in childbirth has huge effects, not just for that woman and her immediate family, but for her broader community. But we also talk a lot about maternal mortality because deaths are easy to count. And women who survive are harder to count. they go home and they deal with the long-term effects of having a life-threatening complication, of having a near-death experience. Their partners live with that, of knowing that maybe they were asked by healthcare professionals to make the decision about who to save. And we don't talk a lot about that. And one of the things that I'm so grateful to this community for is that in really pushing the tide on postpartum hemorrhage, not just maternal mortality, but postpartum hemorrhage as a topic, right? We're not just addressing those mortality numbers, but we're also addressing the, nearly 1 in 10 women who experience a PPH at some point in their lives, most of whom do survive, but maybe aren't able to have another child that would have been wanted, maybe are, but are really concerned about what that will mean for their own safety and for their family's well-being. And so I'm grateful to you, Geeta, for lifting this question up. I think that the work that we're doing together really is focused on also addressing the near miss and the cases that maybe aren't completely life-threatening, but are still severe, right? We have lots of tools now in our arsenal for preventing PPH and for addressing PPH much, much earlier. And so I'm hopeful that these interventions will help us to make sure not just that more women are surviving, but that more moms are thriving. Thanks, and over.
Thanks so much, Caitlin. Any last word from you, Giannis?
No, nothing else. Thank you very much.
Thank you. On that actually very passionate note, Caitlin, thank you for that. And thank you so much, Giannis, for your presentation and really grounding us in where we are with the roadmap and where we're headed, and to be looking for the new consolidated guidelines in the toolkit. So thanks so much. Okay, next slide. Okay, I'm going to turn this over to my steering committee colleague, Hadija. Please take it away.
Cherry, you're able to hear me?
Absolutely, thank you.
Okay, thank you so much, Cherry, and thank you so much for moderating the session. It was actually a very wonderful session. I didn't wanting to end, and Dr. Leonis, thank you so much for being able to answer the questions. So my name is Hadija, as introduced earlier. Today I'm a midwife, and I work with the Reproductive and Child Health Department at the Ministry of Health, and also part of the PPH subcommittee. And I, of course, do a lot of work around postpartum hemorrhage and accelerating efforts and advocacy efforts around PPH in my country. So today in this session, we basically want to speak about midwifery in medicine, and then talking about collaboration between the obstetricians and the midwives to address postpartum hemorrhage. Taking a case like for my country, Uganda, which is a low middle income country, one of the good practices that we have done around advocacy efforts to address PPH is having reviews of mothers that have died. Of course, every Monday and then Thursday on our MPDSR, we have an opportunity to review cases of different mothers that have died, not only due to PPH, but different maternal causes. But sometimes we notice that there are gaps between communication between the care providers, especially between the midwives and then the obstetricians. And then also when it comes to emergency cases where we think that communication should not really be a problem, scope of practice for providing care for the mother should not really be a problem, but we see those things coming up in low and middle income countries specifically. But I do also hope that it may not really be different in the other countries. So in this session, we really want to understand what, according to the training, what does it take to have a competent midwife who will be in return able to prevent and manage PPH? And of course, we want to hear this perspective from ICM, that is the International Confederation of Midwives, where we feel that that is where the midwives to fall. And also just to understand a little bit from FIGO side, what is that can be done to support midwives? Because of course we understand that yes, there's a scope of practice for midwives. There is a scope of practice for the obstetricians and the gynecologists. But when we are working on this one mother, we want to bring our both scopes and then work collaboratively to make sure that this mother is saved. And of course, as they said, PPH has very many devastating effects. Some mothers survive, but after surviving, they equally go back with other consequences. So we want to understand what is that we can do. And at this particular time, I do have my speaker, that is Professor Jacqueline from ICM. And Prof, we really want to thank you so much for honoring our invitation. And of course, as midwives, we want to hear that powerful voice from you to empower midwives, to tell them that, check, you are the niche when it comes to the prevention of postpartum hemorrhage, but also when it comes to the management of PPH, we want to understand where does your scope stop, so that you know that this is not my case, and when are you supposed to call in the obstetrician to support? Because at the end of the day, we want to see a healthy mother and a healthy baby. So colleagues, maybe we can go to the next slide so that I'm able to introduce Prof. Jacqueline. Yes, Prof. Jacqueline is the Chief Midwife at the International Confederation of Midwives. She's a very powerful midwife, actually. And I know the midwives out there are very happy to see that, yes, there's really representation. I happened to attend the summit in Dubai, but one thing that always amuses me when I find the obstetricians who were part, they keep saying that I was very keen at seeing that there is representation of the midwives at everything, every advocacy effort that is geared to see that we accelerate all the interventions to reduce postpartum hemorrhage. So for this point, I know, Prof, you'll be able to empower the midwives, and then we want to hear those powerful voices, and then, yes, so that we are able to move on. Over to you, Prof.
Thank you so much, and thank you for inviting me to speak and share our perspectives on midwives and midwifery in this really significant and important area of healthcare. A fine line between life and death in some parts of the world. Firstly, I'm delighted to be working for the ICM, the International Confederation of Midwives. I've been here now for 1 year and 5 months, having relocated from the UK to the Netherlands to take up this post. I'm currently in Germany at the moment for our regional conference, but I'm delighted to be working for an organisation where some of you may well be familiar with the fact that ICM has 139 members across 119 countries, and we represent the voice of over 1 million midwives. And that, of course, creates an opportunity to make a difference to midwives and the midwifery profession. And indeed, the impact of our care on the outcomes and experiences of mums and babies. That's why we're here. That's why this webinar is focused how it is. So the recommendations outlined in the PPH roadmap, you've heard a little of those, and you've obviously had a look at that document yourself. That, you know, these recommendations will undoubtedly, if they're implemented and sustained by appropriately trained and qualified health professionals, midwives, obstetricians, these interventions will undoubtedly save lives. But as we know, there is so much to do to turn these recommendations and the forthcoming recommendations from the toolkit, etc., into practice. The question can now be, how can any guidance, evidence, intervention on paper make a difference in a practical sense? Because that's where we need to focus now. Sadly, we know the context of providing care where a life is lost and a life isn't saved. And I'll share some of the challenges related to midwife scope of practice as we progress through this presentation. So I'll go on to my first slide. And I am sharing this only to contextualize my talk. I know you have seen this. I know you have heard it. We know it's an unacceptable reality, but I'll never tire of showing this information. And I frequently think about numbers, the numbers obscuring the human experience behind every single person that dies, every single near miss, there is a real person, a real family, a real aunt, a real sister, a real niece, a real friend. And I think sometimes we exist in the numbers, but actually there is a real person. Numbers are absolutely necessary, but they absolutely obscure the human experience. This is an unacceptable reality. In some parts of the world, women do not die of postpartum hemorrhage. And yet I won't re-emphasize the challenges of providing midwifery care in certain contexts, just by the very nature of where you might be born, the very nature of the color of your skin, of your socioeconomic status will determine what happens to you when that labor starts. On to the next slide, please. So midwives, of course, play a significant role in the management of PPH. And I'm going to share with you a few of the key areas from an ICM perspective. But we know that midwives, educated, regulated and trained, will be able to step into that prevention space, early detection and management space, mobilizing other professional team members, if of course they are accessible and not 3 days walk away. Emergency management, if it is accessible. Investigating causes, if there is an infrastructure or even a desire to want to investigate. We investigate to learn. So we have to have a learning environment. Midwives play a significant role in enhancing uterine contractions, repair of perineal repair and transfers, etc. We are familiar with these key areas, but how do we operationalize them with a good infrastructure that can save a life? And despite the existence of recommended interventions for prevention, detecting and treating postpartum hemorrhage effectively, we have effective implementation of evidence-based interventions, but in many parts of the world, this is not robust and it's lagged, so it isn't catching up. Rather, the evidence isn't aligned with the practice. And we see here all these things on this slide. Of course, we can know them, but how do you operationalize them? And so a key area really for saving lives and placing women at the center of a political agenda at subnational, national and international levels is where it's at and where we really need to focus our efforts. But before we go there, let's just go on to the next slide and let's have a look at going a little back to basics. And I make no apology for sharing this slide with you, simply because I'm going to be talking about a return on investment. If you have a midwife, you save a life. But sadly, across the globe, we do not have a consistently recognized description of a midwife. At the ICM, we have the ICM definition of a midwife, and our desire and our aspiration is that every country in the world uses this definition and, on the right of your screen, scope of practice. What we find is in some areas a midwife is a community practitioner that's maybe had 6 months midwifery education, or indeed a traditional birth attendant that has had a few weeks of education, or a hybrid version of any one of those, or indeed a nurse that has had 4 weeks or 6 weeks or even a year exposure to midwives and midwifery and a program of education. But I want to just commend the ICM definition of a midwife to you. Why? Because the evidence, the empirical evidence, tells us that if you have a midwife like this, with this scope of practice, that is educated and regulated and working within an established health system, you will have a midwife that can save a life. And I know that there's more to saving a life than having an educated person and a guideline. But first of all, starting with the basics, a midwife is a person who has successfully completed a midwifery education program based on the ICM essential competencies for midwifery practice and the framework of the ICM global standards for midwifery education, recognized in the country where it is located, who has acquired the requisite qualifications to be registered and or legally licensed to practice midwifery and use the title midwife, and who demonstrates competency in the scope of practice of the midwife. So you can see the scope of practice there yourself. It's really, really important to understand the scope of practice, but even more important to understand the definition of the midwife, and that's why I've read that out. But you'll see and access all these things on the ICM website, and certainly the type of midwife that the evidence says will save a life is this type of midwife that you see on the screen here. And of course, the scope of practice is equally as significant. And I'm going to talk to you about the essential competencies shortly, because the essential competencies for midwifery practice, global essential competencies for our profession, have been updated this year. So let's go on to the next slide, please. So as I've said, midwives educated and regulated to ICM standards and integrated into well-functioning health systems can provide 87% of essential care for women and newborns. Some of you would have seen this slide before, but I ask you to look at this slide with refreshed eyes when we move on to the preventative aspects of postpartum hemorrhage and reflecting on what you've heard thus far from the speaker before me. Look what midwives can avert if they are educated and regulated to ICM standards. Look what midwives can improve if educated and regulated. And look what midwives can provide if educated and regulated. And of course, reducing the chances of stillbirths through good antenatal care. On to the next slide, please. And of course, lastly, I'm going to, before I go on to very specific items in relation to postpartum hemorrhage, I just want to focus a little on why we are pushing and why I'm amplifying and continually trying to focus through our midwives associations globally that you will only save 4.3 million lives per year if you have a midwife that's educated and regulated. You will only save 2.2 million lives per year. And that's a less ambitious 25% increase in the coverage of midwife-delivered interventions every 5 years. But you'll only do that if we go back to the definition and scope of practice of a midwife. And so really, really important to focus on, if we want to achieve these outcomes, then we need to make sure that we are calling a midwife based on the definition of the ICM's definition and scope of practice. On to the next slide, please. So some of the challenges then, so now we know the size of some of our challenges in terms of the problem. We know the definition, the scope of practice, where ICM sits in that space, what the evidence is saying about midwives saving a life. We now have an educated, regulated midwife. We now have guidance, and we now have evidence-based practice. Or we now have evidence, and yet, we are still having these challenges. We need to focus on some of the challenges in relation to equity and access to care, women's rights and social status, lack of education. We know that cultural norms really constrain women's choices around pregnancy and childbearing. We know that it's a real challenge, I think, in some cultures where discouraging or delaying care seeking and not allowing sufficient recovery time for after birth before resuming all the tasks that women have to embrace in some cultures can create a challenge. We know that the risk factors for PPH, including, for example, anemia, grand multiparity, and so on. If the midwife isn't in a context where they are enabled to do their jobs well, then that knowledge is meaningless. Because if the infrastructure isn't there, then that knowledge is meaningless. So really, really important, I think, to focus on these challenges, advocating for women's rights, women's health and rights, and our midwives associations are in some places really at the forefront of advocating for women's health and rights, improving equity, access to quality care, and enhancing service delivery infrastructures, and that's at a government health system level. Improving transportation and referral systems, of course, this will help to ensure timely intervention. And of course, governments must also take absolutely bold steps to develop financing plans that support midwives, obstetricians, and support staff to do their jobs well. Impossible without it, but certainly the equity lens in relation to postpartum hemorrhage is really, really stark. And vulnerable and marginalised groups, we know, are succumbing to poorer outcomes than their advantaged counterparts, social status, etc. So moving on to the next slide, let's have a look at some of the other challenges. PPH guidance. Now, we've heard a little about guidance thus far, and you'll hear more about guidance as this webinar progresses over the next day or so. We know that PPH guidelines in some areas of the globe are out of date. Clinical protocols aren't available, they're not accessible, they're not used, or indeed they're not appropriate to be used. And then, of course, there's the lack of expertise where there isn't education and training for midwives to maintain their skills in preventing. So that's risk assessment, surveillance, antenatal care, labour care, where their expertise will inhibit, reduce the chances of, stop, pause, postpartum hemorrhage until such time that other interventions can come into play. And I'm thinking about more rural areas now. Is really, really important. Of course, in the absence of investment, we won't get very far. So this again is pressing into health system leaders, governments and policy leads to really think about if we want to make any change in our postpartum hemorrhage numbers, then we really need to focus on those people that can make a difference. And I'm really standing in the space of midwives here. Unclear referral pathways do not help. And I'm talking about unclear referral pathways between levels of care and community, where women should go, where providers should refer women for childbirth or emergency care, transport issues, staffing, training, supervision of healthcare workers. We know this, and these things need to improve. But they can't improve unless we have leaders advocating. So as we've heard with the previous speakers, and as I reiterate again, we can have the training, the supervision, the audit, the investment, but we also need to have the guidance that is pragmatic enough to be translated into practice and an infrastructure that allows that to work well. On to the next slide, please. Other challenges, and I'm sure you're familiar with some of these: lack of clear national health policy and leadership. And again, I can't emphasize this enough. In the absence of government commitment, system leader commitment for clear policy, an enabling environment and leadership, we won't get very far. And just thinking about some of the solutions of building clear national health policy and strengthening leadership, midwifery leadership at ministry level, at regional level, at national level, and within the health facility, hospital context level is really important. We know that there are weak procurement and supply chains, and frequently I think about some of the experiences that midwives have shared with me, where they are skilled and educated, but the drugs that they are using to manage and stop a PPH are not fit for purpose. What do you do as a health professional in that situation when you are miles away from a CMONC or a BMONC facility? Poor staffing, training, supervision, but of course, being solution focused, improving the availability of and access to quality assured and affordable PPH commodities at all levels of the health system is a way forward. Ensuring availability of competent health workers to provide relevant, good quality services and commodities is a really important focus. So how do we do any of this? Let's go back to the midwife. Onto the next slide, please. And thinking about the professions framework. So we know the evidence. We know what type of midwife we need, the definition and the scope, the essential competencies. We know some of the challenges that exist across the world, and more importantly, the challenges that exist in places where there's an inequality in health outcomes. I press into the professions framework. This is the professional framework for midwifery. It is the professions framework. And as you can see, there are 10 interrelated elements, and all these elements are interdependent one to another. Right at the center of this framework is the midwifery philosophy and the essential competencies for midwifery practice. And then in the next circle, we have leadership, research, continuity of care, education, regulation, and of course, midwives associations. And each of those are inextricably linked, because if you haven't got the leadership, how can there be a voice to ministry, to health system leaders? How can there be a voice to advocate for evidence-based practice in midwifery? How can the associations be strong enough in the absence of having a leader in an association to set one up and to ensure that the association is meeting the needs of members and its country context in the space of midwives and midwifery? In the absence of regulation, how can we ensure regulated, safe midwives, professional development, and all the things that come with good regulation. In the absence of regulation, how can we have education that is framed on the ICM global standards for education, and indeed reflective of the ICM essential competencies? So this framework is really important, and we believe at the ICM that if this framework was implemented in full, we would have high quality midwifery care. If we have high quality midwifery care, we improve outcomes, reduce morbidity, save lives, and improve experiences. But that said, everything in the inner circle, the philosophy, the essential competencies, leadership, association, research, continuity, regulation, education, if we haven't got an enabling environment, and that's the next circle out, the enabling environment, everything inside the circle is boundaried by an enabling environment. So it goes back to, if we haven't got drugs that are appropriate and fit for purpose, if we haven't got midwives that are educated and regulated, if we haven't got appropriate kit to do the job well, if we haven't got an infrastructure that allows transport links, referral pathways, if we haven't got continuing professional development, then we're not going to get very far with the inner circle of the model. And then, of course, gender equity, boundaries, everything, and underpins everything that we do. So that's the framework in a nutshell. And we urge every midwives association to continue to share this with their governments, ministries, and of course, health system leaders. Let's go on to the next slide, please. So in relation to scope of practice, how can the scope of practice of a midwife assist in ensuring that the midwife is educated and trained to be able to use preventative measures, risk assessment, risk surveillance, clinical management of a postpartum hemorrhage? What does the scope say about this? Well, I'm sharing with you on the screen the essential competencies for midwifery practice, and these were updated only a few months ago. You saw that they were placed in the centre of the professions framework, which was the slide before. But these essential competencies, they outline the minimum knowledge, skills, and professional behaviours required to use the designation, the name, title, midwife, as defined by the ICM on entering midwifery practice. So these are pre-service essential competencies. Some of you may know that they are reviewed and refined every 5 years. These are global, so they're for the midwives everywhere. They are reviewed and refined every 5 years to ensure that they align to the global need and indeed are reflective of emerging evidence across the scope of sexual, reproductive, maternal, newborn, and adolescent health, and of course midwifery practice. And if these competencies were used by midwifery education providers globally, we would see less unwarranted variation in how midwives are educated and practice. And this would, of course, enhance the safety and quality of care. And that, of course, includes postpartum, the prevention, surveillance, risk assessment, and management of postpartum hemorrhage. So really, really important for us that these competencies are known and understood in terms of what they are, how they're used, and so on. It's also important to use the essential competencies alongside the international definition, of course, and scope of practice of a midwife, which I've shared. So really ensuring that midwives are trained, educated, as I've said before. So these competencies that you see in front of you, we have a new competency. And this was only, as I've said, developed this year. So the new competencies were published about 4 months ago now. So we have the cross-functional competencies, which you're familiar with, but they have been refreshed. The new category is sexual and reproductive health. So this is brand new this year, and I commend this to you. Competencies in this category are about the midwife's broader role in sexual and reproductive health care, counselling and education, including contraception, preconception and comprehensive abortion care. And so on. So that's the new category. And then, of course, the antenatal care has been refreshed, care during labour has been refreshed, and ongoing care of women and newborns has been refreshed. In relation to the management, detection, risk surveillance, good antenatal care and prevention of postpartum hemorrhage, I commend one of the competencies that it's entitled Recognising Abnormalities and Complications and Provide Appropriate Treatment and Referral when necessary. So in that particular competency requires that there is knowledge about complications, pathological conditions related to health status, emergency interventions such as what's needed for postpartum hemorrhage prevention, risk surveillance and management. And of course, in the skills and behaviour section of this particular section of the competency, we refer to the skills and behaviour of a midwife is providing emergency obstetric and newborn care, including basic emergency obstetric and newborn care in a BMONC facility. And that is really, really important for saving a life, as you're all familiar with. And also comprehensive emergency obstetric and newborn care, the CMONC. So these items are very explicit now in the essential competencies for midwifery practice. I also commend another subcategory of these new competencies, and that refers to prescribe, dispense and administer medicines or products. And in the knowledge section, midwives, the essential competencies refer to midwives having basic pharmacological and prescribing medicines and products within the midwifery scope of practice according to the legal requirements within country, and the knowledge required for that goes on. So I commend this for you to look at, the essential competencies. But the skills and behaviour within this section also refers to managing in an emergency, documenting and administering appropriate medications in line with national guidelines and protocols for BMONC, and so on. So management of PPH is very much front and centre of this particular subcategory within the essential competencies. And just one more. I mean, there are so many, and there are too many to talk about here, but just one more that I will commend to you. And it's a subcategory of the essential competencies: manage a safe, spontaneous vaginal birth, prevent and manage complications. And again, in the knowledge section, management of emergencies are covered in an emergency skills training program. And again, there is reference to the skills that midwives require, including being able to refer into and work within a BMONC, CMONC facility. And I could go on, but I commend the essential competencies to you. So we've been on a little journey. We've talked a little about the size of the problem, some of the challenges, how we can solve those challenges through good midwifery care. What is a midwife? Why a midwife might not be able to improve outcomes and save lives simply because they aren't enabled through an enabling environment to do that, or there is no recognised continuing professional development, or indeed drills and skills that will equip a midwife to work to their best potential. And as the evidence says, save lives. We then moved on to the professional framework for midwifery, and we still stand on our ambition that if every country implemented and sustained the implementation of the professional framework for midwifery, we would see better quality care and high and good outcomes for mums and babies. And then, of course, we went into the essential competencies. So just on to the last slide, please. So I don't say this glibly, but what midwives do will ripple through generations, absolutely ripple through generations. But the stakes are high, and for every person that is in a leadership position in a health system, a ministry, the stakes are high. And so in those positions, we really do need to advocate for midwives to be enabled to do their jobs well, starting with education, with regulation, evidence-based practice, midwife models of care, scope of practice according to the ICM standards, because the stakes are high. And what midwives do ripples through generations. So every woman and baby deserve the right to have the same, not less, but the same maternity outcomes and experiences as those who have the best. And today, right now, this is our time to try and make a difference in this space. And whilst the problems may be big and wide, an incremental improvement is better than none at all. So I commend, if you haven't seen the roadmap and if you're not excited about what's going to be happening in the future with the toolkit and other tools, I commend these things to you because the stakes are high and this is our time to make a difference. Thank you.
Wow, lovely. Thank you so much, Prof. Jacqueline, for taking us through that wonderful session, speaking about the scope of practice for midwives, and also bringing up the commitments from the ICM side, and of course, empowering the midwifery associations to make sure that they are at the top of the game. And also seeing that some of the efforts that are brought about by WHO, they are pushed down to the midwifery associations to make sure that the midwives are empowered, they're up to date, and they know that the current guidelines. So, Prof, I have a couple of questions right now, and they're quite amazing questions. Of course, you know, when you're speaking about midwifery, the whole world is listening because we know that midwives are so critical, not only in the prevention and management of PPH, but we know that if midwives are supported, they are enabled, they are educated, they are competent, we assure that there will be a lot of maternal and newborn deaths that are averted in this world. So, Prof, allow me to take you through some of the questions. And of course, one is, how can we overcome the challenge of midwives not engaging with midwifery associations due to a lack of trust or concerns about political influence particularly when these associations are not functioning effectively in order to strengthen midwifery leadership and advocacy?
Thank you, and that's a great question. And initially, as you spoke, my heart sank really to think about the fact that there are midwives that are wanting to engage with an association but have these concerns that are real concerns. And all I can say is try, and that there's usually an executive within a midwives association. So if you can't have an inroad and a confidential conversation with one member of the executive, you might be able to have a conversation with somebody else that can help you to have your voice heard. And that may well be through a meeting. If a meeting isn't possible, which I appreciate, it might not be, you might want to send an email or write a letter or just share your concerns. Because if we don't start pulling together as midwives, then there is very little hope for improving maternity outcomes and experiences. We really need to pull together, and we have to put our personal agendas aside, our personal striving to be a certain way, and focus on why we are here. And we are here to serve mums and babies. And so I am really sorry that that person is having that experience. I have heard this in other spaces as well. And my advice has always been, find somebody that you can have some that is a confidant, that you can have a discreet conversation with, to try and navigate a way to let your view known. And usually people will listen to the fact that this is about mums and babies. This is not about us and our agenda.
Mm-hmm. Okay, yeah, thank you so much, Prof, for that wonderful answer. And actually, so many times I tell people that midwives are equally mothers and they also have babies. So usually when we are advocating for anything better for the mothers, it means that we are also advocating for ourselves as midwives and also as health workers. Another great question here, Prof, is how can we ensure that midwives' leadership is recognized and that they are included as key decision makers at that table in discussions of women's health, especially in low and middle income countries?
A great question, and we recognise that midwifery leaders are absolutely essential in moving the dial on improvement for maternal and perinatal mortality, and that is evidence-based. And so at the ICM, we have, I've written a leadership plan. It's an internal document, but it will drive our strategic priorities in relation to leadership. So there will be development of leadership competencies, ICM, midwifery leadership competencies. That will be hopefully out toward the end of next year. There will also be leadership implementation plans, leadership 12-point plan, leadership framework, all next year, and an ICM leadership academy. But I recognise that even building all these things next year, we will have to draw closer to our midwives associations to really strengthen the narrative for some associations so that they can be supported in their narrative for a midwife at ministerial level. Where there is a chief nurse, there also needs to be a chief midwife. And indeed, a midwife, a chief midwife, senior midwives, directors of midwifery, having a seat at the table. But it's really important. There's no point in having a seat at the table if you haven't got a credible narrative to share. So there's a lot to do. Some countries are doing better than others, and I'm delighted to be supporting Jane Francis in Uganda and Madam Daphne in Zambia, who are chief midwives in the Global South. And I'm looking for others. So if there are more, then please let me know, because we have a global chief midwives community of practice that is gaining momentum with 17 chief midwives from around the globe.
Oh, thank you so much, Prof. Proudly associated to Jane Francis, and we're actually working so closely. But I also know there are so many midwives out there that can be supported to actually be good leaders, so that we are really part of the decision making. But I'm also happy that for us in Uganda, we are really doing a lot of advocacy to make sure that, yes, midwives are really included. Now, Prof, giving an experience from Uganda, many times when a midwife loses a mother, there is this perception that the community thinks that, okay, this is a midwife, she has lost her mother, and that's the end of it. They don't even think that we get nightmares in the night because you've lost a mother due to PPH. And we also have midwives that serve in the humanitarian settings, and of course, you know what that means. So, is there any guidance from ICM to support midwives on issues of mental health on, mental health issues for midwives? Maybe they have gone through traumatic stress, a loss of mother due to PPH. I'm just wondering, is there any guidance like that?
A really, really good question. And it reminds me of who cares for the carer, who is actually caring for the carer. And certainly as some of our colleagues, particularly Niha and Lisa Lotta, midwives at the ICM head office, who have been really supporting in the humanitarian and climate crises space, have been pressing in to that request for pastoral support, mental health support. And we have much in the way of respectful maternity care, and respectful maternity care goes two ways, of course, but we haven't got anything specific on caring the carer, but it is associated with respectful maternity care. And certainly I think Niha and Lisa Lotta may well be looking at ways of supporting midwives with that mental health challenge, because whilst the midwife gives the best that they can to the woman and the family, then they're left to pick up the pieces for themselves.
Okay, thank you, Prof. But my question is still on that. How do we make sure that these do not only stop at the global level, just like the way we are speaking about WHO having the PPH roadmap, and where we see the problem is basically on the implementation? So for me, I'm a midwife. Me as a midwife who is coming from the low middle income country, how do I see that the global guidance from ICM is translated to the woman down in one of the villages where they serve their mothers? I'm just wondering, is that through professional associations, or I'm just wondering?
It's a really good question, Hadija, and I'm really pleased that you brought us right back to where the mum and the baby is, right at that interface between midwife, mum and baby. And I think every midwife that has, we believe every midwife's a leader, you included. And so if there is, where there is guidance, that does need to be taken by each and every one of us. Midwives associations, of course, can help because they're our members. But also I think every midwife where guidance, where there is guidance on respectful maternity care, we have a toolkit on the website. Just take that guidance and use it and implement it. And where you need help with implementation, press into your midwives association. But all midwives are leaders. We all have different capabilities, but just remember that these tools are here for you, so you don't need a hierarchy that tells you what to do and when to do it. Of course, resource is important, but being kind, compassionate and considerate and supporting each other costs nothing. think Khadijah's frozen.
I think you're right. We
Prof, I
lost
lost you.
Khadija. Go ahead. Can you
Mm.
see the question still, Khadija? If not, I can take over. Go ahead.
Oh,
I'll move ahead to the next question while
Prof, sorry. Oh, okay.
you go ahead, Khadija. You can fix your connection. I'll move ahead to the next question. We had a question come in about what work is ICM doing to support interprofessional education, especially with obstetricians, considering collaborative care is so important around PPH. Thank you.
Absolutely. Great question. And I'm so sorry that the president of FIGO isn't here, Anne Chiara. She is an absolute friend of midwives and supporter of interdisciplinary, multidisciplinary working. And Anne and I have had long conversations about joining forces, role modeling to midwives and obstetricians globally, that together we can, but divided we are exceptionally weak. So it's that role modeling, it's that pairing, we're speaking, we're demonstrating through our work with FIGO, ICM and WHO on the development of the consolidated guidelines that Jan has talked about. We are working together on that. So really pulling together now FIGO and ICM and focusing on the guidelines. We've got a webinar coming up in a few weeks' time on this very subject. Aditya is going to be one of our speakers, and we're really wanting to step into this more local space about how an obstetrician and a midwife work hand in hand to prevent, risk assess, manage postpartum hemorrhage. Really important question. You're on mute, Jennifer.
Thank you. Absolutely. Yes. Thank you so much. One additional question is ICM providing any guidance at all for this situation that midwives find themselves in, which is unable to respond to a PPH because it's not actually within their scope of practice. For example, in the competencies, giving medications independently, putting an IV, manual removal of placenta, or repairing a laceration. If it's not in their national scope of practice, what kind of guidance can you offer to those midwives? Thank you.
Really good question again, and we revised the essential competencies because we wanted them to be responsive to the needs. So we have the essential competencies. What we need, the reason why I pushed the definition of a midwife, the scope of practice of a midwife, the professional framework, is because they are our tools for countries to improve midwifery practice. If countries want to improve their maternal mortality rates, maternal morbidity and maternity experience of women and families, then they need to implement the professional framework of midwifery. The answer is in the framework. And I will say that we are working on an implementation guide for the professional framework of midwifery, because we're conscious that many countries don't know how to use the framework to get traction at ministry level. So that implementation guide will be out very, very soon, toward the end of this year, if not early next year. And that will absolutely, we hope, help midwives associations and other stakeholders to advocate for all these things that are required to assist a midwife to be able to practice well when managing a postpartum hemorrhage.
That's great. That's really good to hear. We did have an anonymous question come into the chat. Can you give us an example of where FIGO and ICM have done work in country to support guideline or clinical protocol adaptation, if there has been any?
Well, we have the first bit of work that we started on is the consolidated guidance. So we after a huge meeting in South Africa last year, a PPH summit, the output of that was the development of consolidated guidelines. So that's what we're doing globally. These will obviously be ready, hopefully next year, early next year, maybe mid next year. I'm not quite sure whether Johannes has shared a time frame for the publication of the consolidated guidelines. But that's the only example I can give. And what I will say is once those guidelines are published, then there will be an implementation process for how these can be used locally. But in terms of FIGO and ICM working together prior to that, I can't give any examples, I'm afraid.
Well, we look forward to that because I think that's really going to strengthen our response to PPH. I want to thank you so much, Jacqueline, and everyone for the flexibility that we have. I'm going to turn it briefly over back to Hadija so she can wrap up. I know she's having rain, but she's anxious to close, and I think just audio she'll be able to do for us. So go ahead, Hadija, if you're able. If not, I can close out for you.
Thank you so much, Jennifer, and thank you so much, Prof, for the wonderful session. The way the internet has humbled me is the same way PPH humbles midwives in a way. What do I have to say to this? To any person, partners that are here, ICM, FIGO, WHO, we really request for support towards the midwives. As long as midwives are enabled to work to their full scope of practice, we shall be able to avert so many deaths due to postpartum hemorrhage. When midwives are given the right uterotonics, because of course for us in our low middle income countries, when we speak about prevention, most of the things that come around are the poor uterotonics. I can say poor uterotonics, and those are the same uterotonics that we also use on ourselves. So for me, my advocacy message as I'm closing up should be like, please, we kindly appeal to anyone, provide midwives with enough enabling environment, give us the right uterotonics, give us the right education. Then when it comes to refractory management of PPH, low middle income countries are struggling. There's introduction of so many things. Speak about TXA. TXA is not available. Speak about the UBT. Speak about the NASICs. They're all not available. But we also understand that midwives can't do this alone. I have testified to this in my country that when midwives work collaboratively with the obstetricians, trust me, the mother is going to survive due to postpartum hemorrhage. So it's been really a very wonderful session of sharing. Prof, thank you so much for giving us your insights from the ICM perspective, and my team from the CRN committee. Thank you so much for putting this together and giving me an opportunity to moderate this session. So right now I want to hand it over to my next colleague to take us through the next session. Thank you so much, and over to you, Landry Muhizi.
Thank you so very much, Hadija. Thank you, Prof. Jacqueline, for this brilliant presentation. I will lead the next session. And my name is Landry Muhizi. I work for LifeNet International. And I'm a medical doctor specializing in public health with a particular focus on maternal, newborn, and child health. And at LifeNet, we are an international NGO which works across Africa in 6 countries where we intervene in more than 400 health facilities to offer quality care through providing medical and management training. And I'm also part of the Postpartum Hemorrhage Community of Practice Steering Committee. And after the brilliant sessions that we had before, now we are going to dive into the implementing the postpartum hemorrhage roadmap, where we will have country examples. And don't forget, for participants, if you have any question during the upcoming presentations, to type them in the Q&A box. We will have time just after to discuss about the questions or comments. And in that, we will have two speakers, two country examples from Africa, but from different settings. As we have been speaking in English, we will have at the end a Francophone presenter to take us through one example in a Francophone country, which may bring some color or some difference in what is happening around the world. So our very first presentation will be done by Michael Mutamia. He is a senior regional program advisor at Chipaego, Kenya, and has been working for accelerating measurable progress and leveraging investment for postpartum hemorrhage impact projects in Kenya and other countries for more than 15 years, and he has been providing technical guidance for reproductive, maternal, newborn, child, and adolescent health interventions in low-resource settings. Recently, he has focused on implementing WHO recommendations for PPH prevention and management. He'll be taking us through those components. And welcome, Michael. Over to you.
Yeah, so thank you very much, Landry. If we can go to the next slide, I'll be sharing with you some of the lessons that we have learned in implementing WHO recommendations. Introducing new health products and technologies is not easy. There are hurdles that we have in the process because a new product and technology requires some approvals in the ministry. We need to do a lot of awareness creation and many other things. So I'll be sharing with you an experience of two projects which I've been privileged to be part of. The first one is a Smiles Mothers project that was funded by MSD for Mothers, implemented in 10 counties, 4 facilities, and our focus was introduction of each-stable-carbetocin and tranexamic acid. Next slide, please. I've also been part of a project called Accelerating Measurable Progress and Leveraging Investment for PPH Impact, which is a project that is lighting a spark in 6 countries and seeking to transform the trajectory of PPH across the globe. And I'll focus on this project in my next few slides. Next slide, please. So Ampli-PPHI is a project that is being implemented in 6 countries. You can see them there. We are focusing on each-stable-carbetocin, advanced distribution of misoprostol for PPH prevention, tranexamic acid as part of the first response bundle, and calibrated DREPs. We are organized into 3 objectives where we're generating evidence on feasibility and acceptability and the budget impact of these innovations. We're also creating an enabling environment in these countries so that we have providers who are competent in terms of skills. We have advocacy, and when we talk about advocacy, we know that not all of us were born as advocates. There's a structured way of doing advocacy, and we use the SMART advocacy approach where we use 9 steps. I don't have time to go through these steps, but what is important is bringing partners together to agree on what our asks are, and then determining who are our decision makers and approaching them with evidence and data so that they can be able to make the right decisions. We're also focusing on market shaping through overcoming supply side barriers, especially upstream and also downstream, and I'll be able to share with you how. Next slide. So before I proceed, I think it's important for me to show this slide because I know when I tell you the story of this slide, you'll be keen to listen to some of the insights that I'll be sharing. Since we started implementation in Makueni County, which is a county in Kenya, we have seen 0 maternal deaths due to PPH in 2023 and 2024, from 12 in 2022. We know in 2020 and 2021 was the peak of COVID, and therefore data might not have been very good. But what I'm sure and what I know is that that reduction is not by chance. We cannot attribute it to ampli PPHI only, but we know it's not by chance. So what this slide tells us that it is possible to implement these innovations and have results. Just a disclaimer to say that we are implementing these interventions with quality assured medicines. That is something that we need to underline and capitalize and talk about, because we know very well that we have a challenge in quality of medicines in our environment. Very disturbing studies at only 2020 showing that almost 40% of oxytocin that we have does not meet quality standards, 40% of misoprostol, 75% of igometrin. Again, emotive trials showing that out of 17 unique samples of oxytocin, only 6 met the quality standards. Same for tranexamic acid, out of 14, only 10. So unless we address the issue of quality of medicines, we may not see the results that we want to see, and we need to collaborate, and I'll be sharing some insights and thoughts on how we can address that. Next slide. So the way we look at introduction of health products and technologies is through the steps that you can see there. I'll not go through them, but I'll focus on the lessons. But what we've learned is that introduction of stringent regulatory authority approved products or WHO pre-qualified product is easy because there's trust among key stakeholders. And then a product that is within the WHO essential medicines list is very easy to introduce. I want to acknowledge the World Organization for the work they are doing in terms of making sure that these essential medicines are within their essential medicines list. It really makes a lot of difference. We also need to invest in awareness creation. The governor of Makueni County is our national champion for PPH. And one of the statements that he mentioned in one of our meetings is that we are not communicating on what we need, how it can be done, and what are the results. So that is a decision maker. So we need to do a better job. We might have some very good results from the emotive trial, from the champion trial, from the woman trial, but are we communicating those results in a language that decision makers can understand? So the answer is no. We need to do a better job in terms of awareness creation to say what works, how can it be done, how much does it cost, and what it will take to roll down, and to the right people. And that is something that has been missing. We've been able to do that in Kenya, and I'll share with you some of the results that we've been able to see. Again, product registration can take a lot of time, and they really need to invest in that. It's also good to know that global evidence may not automatically be accepted, and in some countries, there's emphasis for small demonstrations. We may need to do that, but I really appeal to the countries that are represented here to consider moving and running with this evidence. It's so solid that we don't need to take so much more time at testing what has already been tested. So I think the scientific rigor was so good. It's good to take what works to scale, especially if there's evidence and there's all the evidence that we need. Next slide, please. So the next phase is now, once these guidelines are out, we need to go to phase 2, and the steps are right there on your left. We need to create awareness, we need to update national guidelines, essential medicines list at the country level. We need to update the health information system and update training materials, as well as develop a national costed implementation plan so that it can have a coordinated way of doing this. So the first thing to note is that we need to, for us to achieve long-term success, we need to institutionalize these innovations, and this can only occur when we have them in policy, in guidelines, and when we are capturing data about this. So it's also very important to note that updating this document is time consuming and it's costly. So we need to be very deliberate in investing in this process and having a multi-stakeholder engagement. Different stakeholders have different interests, but we need to bring them together to speak in one voice for decision makers to listen. Unless we do this, if all of us work parallel to each other, we may not achieve much. We also need to integrate this in our national training package. I know a lot of trainings have been done, but there's value in negotiating for cost-effective, capacity strengthening approaches, especially with more focus at the service delivery point, at the health facility. That is where the rubber meets the road. That is where we need the investment. Professional associations are very key. They have networks across the country. We need to leverage on their presence to take these innovations to each and every service delivery point. Next slide. So this is what I'm talking about. What I've said might be theoretical, but this is what I'm talking about. We've gone through this process as a country in Kenya, from the WHO recommendations to solid policy documents that are driving a scale up in the country. Essential medicines lists updated to allow use of these innovations, especially each-stable-carboxyl tranexamic acid at all levels of health facilities. National guidelines updated to capture these new innovation, including the bundle, quantification, so that we can determine the needs of each county and facility, and updating the national training package and the MNH standards. This is a very important step for us to have institutionalization. Next slide. So once now we have this within the policy documents, we need to quantify the needs that we have for the country. We need to advocate for procurement of these products. And a case in point is an opportunity we leveraged of using direct procurement to have Kenya procure the highest quantities of each-stable-carboxyl from any public sector entity at that time. That is 360,000. These medicines were delivered to Kenya in July. And so far, 30 out of 47 counties have already ordered each-stable-carboxyl, and a lot of awareness has been created. So we need to make sure that these products are available in the national supply chain. Tranexamic acid, good thing, is available in our system. And the idea now is creating awareness so that it can be used within all levels of facilities. So the other issue is training models. We need mama natalies, we need other humanist models for us to conduct competency-based training. And we need to standardize our trainers and monitor how these products are being utilized. So it's very important for us to do quantification and supply planning. And if we are donating any products and technologies, please donate them through the national supply chain, because the moment you use a different system, for example, if you're donating, say, tranexamic acid, and then there was tranexamic acid in the national supply chain, and that tranexamic acid expires, it will kill that national supply system. So we need to donate those within the national supply system so that they can do a supply planning and so that we don't have any expiries or any losses. Again, when we talk about product introduction, we should think more of saturation than targeting multiple geographies. For example, there's no point of touching a few facilities within a county or a district, because when that product is available in that district or county, it will be distributed to all facilities and misuse can be an issue. So you'd rather focus on one county, do a good job there, move to the next. So the other element that you also need to think about is total market approach. I know we are focusing more on the public sector, but like in Kenya, almost a very huge percentage is also served by the faith-based institutions. So we also need to make sure that these products are there. And to that end, we've also made sure that, for example, each-stable-carboxyl is available within METS that serves the faith-based. And then the private sector also contributes to maternal deaths. So if you don't give them these updates, they'll continue dragging us behind. So we need to have a strategy also for focusing on the private sector. We need to have a multi-cadre approach. Not only midwives, not only obstetricians are involved in the care of these women. We also need to think about PPH in theaters. We need to involve anesthetists. We need to involve pharmacists who are involved in ordering these commodities. We also need to involve health records and information officers who will capture quality data. Unless we involve all those cadres, we may not achieve the results that we want to achieve. Next slide. So this is an example of the way, for example, the price of each stable gabetosin has gone down from 2,700 Kenya shillings to 95, available now in the public sector, just like I mentioned, which is a big win for the country. Tranexamic acid is also available, and we're working very hard to make sure that calibrated drips and other innovations are available. Next slide. So change is not easy. And when we started these innovations in Makueni County, we had resistance in some of our quarters, especially from healthcare providers, because this is what they're used to. So you need to have a strategy for change management, especially led by the content experts, obstetricians and midwives, and then we can have champions at the facility level who will drive this change. So that is a very important consideration that we need to think about. Next slide. So as we think about PPH, it's good to think about the bigger strategy, every woman, every newborn, everywhere, because a mother might survive from PPH but die of eclampsia or sepsis. So as a country in Kenya, the ministry has chosen to go the way of a more comprehensive training approach, where you focus on all obstetric emergencies and drive the training at the facility level. Next slide. For us to translate the WHO roadmap that Dr. Gallos talked about, as a country, we've developed a PPH costed implementation plan, which is a critical document for coordinating and giving direction on what needs to be done. Because when some of these innovations come up, many partners want to come in and support, but unless we have a coordinated mechanism, we will lose fidelity to the intervention and do not achieve the results. So for us to have that harmonized implementation plan, making sure that the entire country is covered, we developed this PPH costed implementation plan, borrowing heavily from the roadmap. Next slide. The key components of this CIP are organized in a continuum of care lenses, because if this mother is not taken care of during the preconception care, she might end up with challenges. For example, we know there's a very strong link between anemia and PPH. So we need to have, for example, palatable iron. I know sometimes the iron that our mothers are getting is not palatable. They are given in a facility, but they don't use it. When you look at antenatal care, think about quality nutritional counseling, point of care devices for testing HB. HB testing every trimester. Most of us test only once. And when the mother is coming to give birth, she has very low HB. So we're really in a very compromised situation. Treatment of anemia. Sometimes we test, I know that a mother has anemia, but what are we doing to treat that anemia? The other issue that we need to think about is quality intrapartum care, calibrated drips for all our mothers who are giving birth, quality assured oxytocin. We still need quality assured oxytocin. For example, it's the bocabetocin in some areas where it has value. The first response bundle, quality tranexamic acid, non-pneumatic and shock garment, blood products, and many other things. So these are things that we need to think about in a holistic manner, coupled with quality postnatal care. Next slide. The CIP is organized in different thematic areas, from leadership and governance to financing and sustainability. For us in Kenya, we are advocating for MNH products to be national strategic commodities, so that mobilization of resources is done at the national level. You'll not hear challenges with quality of HIV product, because they are national strategic commodities. If PPH is the leading killer, why don't we make medicines and health products and technologies related to PPH national strategic, so that we have resources that are allocated? So that is work in progress that we are advocating for. Awareness creation, which I talked about. Service delivery, I think I've talked about the trainings at the facility level. I've talked about the updating the health management information system, and also making sure that these products are available. So very many components within this costed implementation plan. We also have a training plan that is very clear. We've already standardized, I think, 2 classes of national TOTs, and now the country is moving towards mobilizing resources to implement this CIP, covering the entire country. And we are calling upon the partners who are here to support Kenya as an early adopter to implement these innovations. Next slide. So this is coordinated through RAMCA, Products and Innovation Steering Committee, that is the RAPTIS committee, among other coordination mechanisms within the country. So that coordination is very key so that we can have that harmonization in terms of implementation. Next slide. Yeah, so we need all of us to nurture these innovations. They are very good innovations, but we need to, team up and then make sure that this flame doesn't go off. And the way we can do that is having Ministry of Affairs, county governments, private sector, implementing partners, academia, regulatory bodies, product developers, and other innovators to be part of this conversation. And then again, as we think about quality of medicines, we need to think about supporting our local manufacturers to manufacture these products nationally, because it costs a lot for us to, for example, import oxytocin from another country. How can we make sure that we support the manufacturers in Africa to produce quality assured oxytocin and these other products for us to be able to really have this product at a low cost and quality products. The other consideration is we need to have technical specifications for these products. For example, you'll not have quality issues with insulin because they have very clear specifications. Must be WHO pre-qualified or SRA approved, and as manufacturers bid for those, for supply of those commodities, they know that they are very specific technical specifications. And when we give technical specifications, we're able to lock out some of these substandard products. So I think that's my submission. I thank you for listening to me. So next slide. We didn't do this work alone. It's been a collaboration between very many partners. These are some of them that we've been working with. And we want to thank you very much for giving us an opportunity to share. Thank you.
Thank you very much, Michael, for this brilliant presentation with a lot of information with your successful intervention in Kenya, implementing this new roadmap. Without taking a lot of time, we would like to invite our next presenter. I'm going to switch to French. Alors,
we're going to take just a very
c'est-
brief break so everybody can switch to English. S'il vous plaît, presque minute pour tous les peuples ici qui parlent anglais. À presque minute, merci. Ouais.
Thank you very much, Jen. Merci beaucoup à tous. Merci beaucoup à Michael pour cette brillante présentation. Maintenant, dans notre suite de cas de pays où la feuille de route est en train d'être implémentée, nous allons accueillir Dr. Chuma Socrate Biamungu, qui est un médecin spécialiste de la santé publique avec plus de 10 ans d'expérience dans les soins à long terme, mais aussi dans le domaine de la santé, de la reproduction et dans la gestion des programmes. Dr. Socrate Chuma est un expert en planification stratégique et dans le développement des lignes directrices et des protocoles et des standards de la santé sexuelle et reproductive, mais aussi dans des interventions en milieu humanitaire et dans des pays en voie de développement sur l'implémentation de l'assurance qualité. Il travaille pour le ministère de la Santé publique de la RDC, précisément dans la province du Sud Kivu, comme l'assistant technique du programme national de la santé reproductive et point focal des violences basées sur le genre. Il va nous présenter brièvement sur la prise en charge de l'hémorragie du postpartum au Sud Kivu, qui va aussi inclure quelques points sur l'adoption des nouvelles lignes directrices. Il va présenter en français, alors il vous est demandé, pour ceux qui parlent anglais, de passer à la traduction. Soyez les bienvenus, Dr. Chuma, à vous le micro.
Okay, merci beaucoup pour la parole. Nous avons travaillé, nous c'était au fait pour la mise en œuvre, au fait, de la stratégie pour lutter contre l'hémorragie dans notre province. Et on va vous parler des stratégies qu'on a pu mettre en œuvre pour pouvoir essayer d'administrer la prise en charge de l'hémorragie. Alors, voilà, donc on va parler de l'ampleur des stratégies et quelques résultats qu'on a pu obtenir. C'est une approche qu'on a commencée il y a 3 ans, pratiquement, dans quelques zones de santé de notre province. Dia. Dia. Oui, Dia, nous, OK. Et comme vous comprenez, notre province avait connu beaucoup de difficultés pour ce qui concerne les décès maternels et depuis des temps, on a essayé beaucoup de stratégies, mais ça n'a pas marché. C'est ainsi que, comme vous le voyez, et les principales causes dans 67% des décès enregistrés ici en province, c'est vraiment les décès maternels. C'est ainsi qu'on devait mettre un focus sur cette approche pour permettre vraiment d'éliter sur ces fléaux. Dia. Dia suivant, s'il vous plaît. OK, ainsi pour y parvenir, nous avons analysé certains facteurs qui ont fait en sorte que ces décès causés par l'hémorragie postpartum, nous avons vu que c'était plus lié au postpartum immédiat et tardif, c'est tout postpartum immédiat. Alors, les facteurs qui ont contribué à cela dans la province, c'était plus un suivi inapproprié ou insuffisant. Il y avait aussi les retards de décision, de référence, une réanimation insuffisante. Il y avait aussi prescription inadéquate et puis retard d'administration des traitements. Il y avait aussi un plan d'accouchement non discuté. Souvent, c'était imposé. On n'impliquait pas les femmes au moment des consultations prénatales pour qu'ils puissent vraiment s'approprier le plan d'accouchement. Et il y avait aussi une prise en charge de mauvaise qualité et surtout liée à une mauvaise évaluation initiale de la mère, ce qui faisait que la plupart des des interventions qu'on mettait en place étaient inappropriées. Alors, pour ça, nous avons adopté quelques stratégies d'élite. La première stratégie, c'était de voir comment lutter contre l'hémorragie en mettant en place des axes d'intervention. La première axe était de renforcer les capacités des sages-femmes, surtout en SOMI, et aussi d'intégrer la planification familiale pour essayer de lutter contre les 3 retards que vous connaissez, de grossesse trop nombreuse, grossesse trop tôt et grossesse trop tard, parce que ça figurait aussi parmi les facteurs qui faisaient qu'on ne savait pas, qui entraînaient plus les hémorragies de postpartum. Et pour cela, après la formation, donc on a formé, par exemple, actuellement, nous sommes au moins à 76% des prestataires ou des sages-femmes qui sont formés en SONI, mais nous avons adopté d'abord une approche qu'on appelle mentorat clinique sous forme de stage. D'abord, ces sages-femmes qui sont formées passent en stage. Nous avons mis en place un centre d'excellence et précisément, c'est ici à l'hôpital général de Panzi. Nous avons donc un centre d'excellence dans lequel les sages-femmes font des stages, travaillent sur donc, des techniques de simulation Et aussi, nous avons aussi adopté notre approche qu'on a mentorat clinique selon l'approche petite dose haute fréquence. La petite dose haute fréquence, ici, c'est plus lié au fait qu'on expose les sages-femmes à une formation, une petite formation accompagnée de pratiques que nous séquençons au moins en 4 modules et chaque module est espacé de 2 mois et accompagne ainsi de suite qu'on va renforcer aussi l'accompagnement. Dia? Alors, pour ça, nous avons quand même, avec cette stratégie, nous avons quand même eu quelques résultats. Depuis 2021, nous sommes passés, pour ce qui est des décès maternels, on était à 106,9 décès pour 100 000 naissances. Nous sommes aujourd'hui, jusqu'au 2023, on est à 81 pour 100 000 naissances vivantes et je pense que le dernier trimestre 2024, on est en train d'aller vers les 60 pour 100 000 naissances vivantes. Donc, ça a produit quand même des résultats très, très importants avec cette approche. Dia. Alors, malgré ça, nous avons quand même beaucoup de défis. Le premier défi, c'était avoir suffisamment de mentors pour implémenter les mentorats cliniques. Normalement, dans les zones de santé où on a mis ça en place, à peu près 10 zones de santé sur 34, et contre la province, on a au moins 6 mentors par zone de santé. Et pour ces 6 mentors, pour le moment, on n'accorde pas suffisamment de temps d'accompagnement parce que vous savez que pour le mentorat clinique, qui est vraiment d'accompagner un prestataire comme il est de l'accompagner dans son travail, on est obligé vraiment de travailler jour et nuit pour permettre d'observer suffisamment de cas cliniques pouvant permettre vraiment d'aider les sages-femmes à former leurs pairs. Et c'est pour ça que pour le moment, on travaille avec 6 jours, 6 jours d'accompagnement chaque trimestre pour chaque maternité. Mais nous avons observé, nous avons remarqué que c'est un peu insuffisant. Aussi, ces sages-femmes qu'on utilise comme mentors, donc ce sont des sages-femmes qualifiées, déjà sélectionnées, qui accompagnent leurs pairs pour les aider à transmettre les compétences nécessaires. Ils sont appuyés par, maintenant qu'on appelle les mentors seniors, qui sont souvent des gynécologues et des pédiatres, qui accompagnent ces sages-femmes pour permettre de renforcer leurs capacités. Et aussi, un autre défi qu'on a observé, c'était la mauvaise qualité de l'ocytocine parce que la chaîne de froid vraiment pose problème dans notre province. Ce n'est pas toutes les maternités qui ont les capacités de pouvoir conserver l'ocytocine dans la température optimale. Alors, ce qui fait que même s'ils ont des ocytocines disponibles, parfois, ça peut ne pas agir du fait que c'est un produit tellement labile, il faut vraiment respecter la température. Dia. Dia suivant, s'il vous plaît. Voilà. Ainsi, comme on avait dit, on est en train, pour essayer de voir comment aider la province, nous avons au moins 34 zones de santé dans la province. Alors, nous sommes en train de chercher comment de quitter des 10 pour aller vers les 34 en mettant les mentorats dans les 34 zones de santé. Et aussi, on fait des plaidoyers pour passer pour chaque zone de santé au moins de 6 à 12 mentors par zone de santé. Mais également, nous avons observé qu'il faut quand même doter les mentors en modèle anatomique qui va leur permettre de transmettre les compétences nécessaires à leurs pairs. C'est ainsi que nous sommes en train de faire un plaidoyer pour acquérir des modèles anatomiques pour permettre à ce que les mentors puissent vraiment être proches des réalités cliniques lorsqu'ils transmettent les compétences techniques. Mais également, nous devons assurer aussi le monitoring, comment on peut mesurer ces progrès au fur du temps, donc à travers les monitorages améliorés par action. Et pour les dynamiques qui viennent de finir leur stade pilote dans la province de Congo central. Maintenant, on vient de briefer, la province vient de briefer les prestataires sur l'utilisation. On attend maintenant le prochain approvisionnement dans ces produits pour voir vraiment si ça va encore booster l'impact pour adresser les problèmes des hémorragies postpartum. Bien. Voilà, merci beaucoup pour votre patience et je suis à votre disposition.
Merci beaucoup, Dr. Chouma, pour votre brève, concise et claire présentation. Je vais voir dans le Q&A si on aurait des questions à votre endroit. Mais en attendant, j'ai une ou deux questions pour vous. Vous nous avez dit que vous êtes en train d'adopter les nouvelles recommandations, notamment l'utilisation de l'acide tranexamique, mais aussi de la carbétocine thermostable. Mais parmi les recommandations, il y a aussi l'utilisation des draps gradués pour pouvoir mesurer de façon objective la perte de sang et pouvoir conclure ou pas sur l'hémorragie du postpartum. Est-ce qu'il y aurait des recommandations dans ce sens qui sont en train aussi d'être mises en pratique, notamment pour la disponibilisation de ces draps gradués? Merci.
OK, merci pour cette question. Pour ce qui concerne les intrants, carbétocine et l'acide tranexamique, nous sommes à la phase d'introduction parce que nous venons de finir le briefing sur les produits, comment l'utiliser. Nous sommes en train d'attendre maintenant l'approvisionnement, le premier approvisionnement de ces produits pour qu'on puisse les mettre. D'abord, on va les mettre dans un premier temps dans les zones où nous avons commencé le mentorat clinique, puis on va passer au fur et à mesure dans d'autres zones, selon qu'on va étendre l'approche. Alors, pour ce qui concerne les draps gradués, c'est une approche, nous avons déjà sensibilisé les sages-femmes sur cette approche. Malheureusement, c'est faute de budget. Faute de budget, la province n'a pas encore décidé l'introduction. Parce qu'on attend aussi qu'on puisse trouver des budgets pour pouvoir garantir la disponibilité de ces draps. Mais on est en train de voir avec projet financé par la Banque mondiale parce qu'eux, au moins, ils ont plus comment on appelle, on peut dire plus de ressources allouées par rapport à la maternité, comme dans notre province, on a adopté aussi la gratuité des accouchements. Donc, au moins dans 23 zones de santé, on pense que prochainement, l'année prochaine, on peut commencer déjà l'introduction aussi de ces draps gradués. Voilà, donc on veut aller palier par palier, et tout aussi en fonction des besoins disponibles, donc des ressources disponibles.
Merci beaucoup. Il y a deux autres questions dans le chat. Quels sont les défis que vous avez rencontrés lors de la formation des sages-femmes par rapport au module SONUC? Parce que vous avez dit que vous en êtes presque à 76%. Il y a éventuellement un quart qui reste, mais même pour les 75%, est-ce que tout s'est bien passé? Est-ce qu'il y aurait eu des défis? Si oui, lesquels?
Oui, bon, les défis d'abord, comme vous venez de les voir, c'est d'abord les ressources disponibles, hein. Pour le moment, on n'a pas obtenu les ressources nécessaires pour pouvoir former donc, la totalité des sages-femmes. Mais on pense que l'année prochaine, on va obtenir les ressources pour compléter. Et on avait aussi perspective de voir comment dans chaque maternité, qu'on puisse former au moins des sages-femmes, hein, pour permettre une meilleure disponibilité en sages-femmes. Mais également, les médecins aussi sont concernés pour ce qui concerne les hôpitaux. Alors, un autre défi qu'on a pu rencontrer, c'était lié en termes, on peut dire, techniques de formation, c'était plus lié à la disponibilité des modèles anatomiques. On n'en avait pas eu suffisamment parce qu'il était recommandé que ces modèles anatomiques puissent rester dans les structures, à défaut, dans chaque zone de santé, de créer des centres de démonstration dans lesquels les sages-femmes peuvent passer pour s'entraîner. Alors, pour l'instant, les modèles anatomiques disponibles sont à la disponibilité des formateurs qui parcourent zone de santé par zone de santé. Et lorsqu'on a réalisé les formations, on était incapable de les faire au même moment parce qu'on devait utiliser les modèles anatomiques partout. Donc, on a fait par pool selon que on disposait des modèles anatomiques. Alors, pour le moment, on fait des plaidoyers auprès de nos partenaires pour pouvoir augmenter ça et aussi augmenter les sites de démonstration dans chaque zone de santé pour voir si on peut élargir la disponibilité des modèles anatomiques. Mais également, bon, d'autres défis, c'est il y a aussi des zones, l'accessibilité géographique, hein. Ce n'est pas évident dans notre province. Il y a des zones à accès difficile pour lesquelles on n'a pas pu faire dans les temps impartis, réaliser ces formations-là. Mais nous comptons, nous sommes en train de faire un plaidoyer pour voir comment est-ce qu'on peut ouvrir ces zones de santé aussi l'année prochaine.
Merci beaucoup, Dr. Chouma. Deux dernières questions à votre endroit. Vous avez parlé d'une stratégie de formation à haute fréquence, petite dose. Est-ce que vous pourriez nous expliquer en détail comment ça se passe? Qui est-ce qui dirige ces formations? Parce que la stratégie semble intéressante et effective. Merci.
Oui, l'approche petite dose haute fréquence, parce qu'on a remarqué que, vous voyez, la Sony, c'est un peu costaud, au minimum 10 jours de formation. Alors, retenir les sages-femmes pendant 10 jours, parfois, ça, non seulement ils ne sont pas concentrés jusqu'à la fin, c'est ainsi qu'on a coupé donc, les formations là en 4 modules. Donc, il y a une module qui dure chaque module, nous prenons 4 jours. Et pendant ces 4 jours, dans chaque module, nous avons des parties théoriques et des parties pratiques, démonstrations et pratiques cliniques. Et on les fait par intervalle au moins de 2 semaines à 1 mois. Donc, un module et puis ainsi de suite. L'avantage aussi, c'est que ceux qui sont formés, normalement, ils sont formés pour être des formateurs aussi, pour pouvoir transmettre aussi à leurs compagnons. C'est ainsi qu'on commence par la formation des formateurs dans un site. Dès que c'est terminé, on peut passer dans les sites donc disséminés maintenant en tâches d'huile dans les différentes zones de santé. Mais la formation des formateurs, elle dure au moins 10 jours où on donne tous les paquets. Mais lorsqu'on part au niveau des formations, des établissements de soins, c'est là où on va créer des sites de formation dans lesquels on va dispenser la formation par paquet, espacé par un temps de pratique où les prestataires pratiquent dans leur formation sanitaire et puis ils reviennent 1 mois après pour entamer le module suivant, ainsi de suite jusqu'à terminer les modules impartis qui sont autour de, je pense, de ces 4 modules en totalité. Mais pour le moment, on a privilégié les 2 premiers modules parce que c'est ce qui est plus dans lesquels on concentre plus Sony et puis la planification familiale. Voilà.
Merci beaucoup, Dr. Chouma. Il y a d'autres questions qu'on pourra vous adresser après, mais merci beaucoup pour votre présentation. Comme le temps imparti file, il y a 2 ou 3 questions pour Michael et je vais revenir à la case en anglais. Merci. Thank you again, Michael, for the presentation. I have 2 questions for you. One is about the new product introduction. As we were talking in the previous presentations about the skepticism of some countries to adopt new drugs because sometimes we don't have enough evidence regarding the local context. How good was the adoption of the new drugs in Kenya? Because seems like for you have it was not complicated. That's my first question. The second one is about the quality of the medicines. We have been talking about oxytocin and misoprostol and ergometrin studies, which showed some of them which were not good. What are some solutions that have been put in place by your project to make sure that the new medicines that are coming in won't have the same issues? Thank you.
Yeah, so thank you very much. So for Kenya, the process was not as simple as you mentioned. It was a heavy investment, starting with the MSD for Mothers project, the Smart Mothers project, where after implementing the project in 10 counties, 4 facilities, we organized a meeting with the key decision makers and organized for the mentors who had an experience of using these medicines, that is ichthyobucabetocin and tranexamic acid, in a meeting, and then they share their experience. And when they shared their experience, the ministry at that point made a decision that that is the way to go. They don't have to wait any longer to do other trials or studies. The evidence was clear from their own experiences that those medicines are making a huge difference. So the same case applies to Makueni County, where we are implementing. After implementing in 36 facilities, actually, over 99% of mothers giving birth are getting ichthyobucabetocin for PPH prevention, and 100% of all the PPH cases have been getting the first response bundle. So from that experience, the county has made a decision to scale up to all the facilities in the county and also procure calibrated drapes for all the facilities and tranexamic acid and also each sebocabetocin. So when an intervention works, it will speak for itself. You don't really have to use a lot of energy to convince decision makers. Just demonstrate. Our healthcare providers use the innovation will speak for itself. And that is the case for this PPH innovation. So when you take that approach and then have professional associations on board, they're the users, they're the ones who spend sleepless nights because of PPH, they'll definitely adopt what works. So that would be my reflection on that. So in terms of quality of medicines, there are a number of interventions that we put in place. The first one is advocacy, because procurement is a function of the government. And then the second one, the main thing that we've advocated for is post-marketing surveillance. So whenever a product is in the market, for example, that is poor quality, withdrawing it from the market is not easy. You need to have evidence, and that can only be generated from post-marketing surveillance, where samples are collected, they're tested, and the results of that testing is what determine what will be done. So the challenge that we have is that when we are mainly testing products for active ingredients, but what we are not doing is testing for related substances. And that is the conversations that we are having, because what we've seen is that the product that was seen to have related substances under the emotive trial were the same products that had issues. So it might be a question of bioavailability as a result of interactions that you're seeing, maybe because of the impurities and the active ingredient. So that is the conversation that we are having. The other conversation that we are having is value-based procurement, because you might buy a product that is very cheap, but ends up becoming very costly. For example, we have a molecule that costs around 13 Kenya shillings. But assuming that this product is not quality, you end up with a PPH, you end up with man hours managing that PPH, you end up giving a uterine balloon tamponade, uterine compression, putting this mother in an ambulance, having this mother in hospital for a long time, having a death as a result of that poor product. So the actual cost of that molecule, when you look at it in totality, is very, very costly. It costs millions because you cannot even value a life of a mother. So we need to think about value-based procurement, and that is the conversation that we're having with our ministries, so that we think about the total value of the product than the face value of the product in terms of it costs this much. So the other conversation is that as we do all these things, there are products that are already known to be quality. Can we prioritize that within our procurement systems so that we have them, even as we try sort out these other quality issues? Yeah, I think that would be my reflection looking at time.
Yeah, thank you very much, Michael, and for sharing this experience from Kenya, and Dr. Chuma for what is happening in DRC, in South Kivu. And we look forward to learn more about what is happening as we share experiences across countries to better save our communities and fight against this avoidable death. So to conclude about our day one, I will call Dr. David to continue moderating. Thank you very much.
Andrew for hello, can you hear me? All right.
Now, very well, thank you.
All right, yeah, thank you so much, Randri, for the introduction and for the great discussions. So my name is Dr. David Nirushwa. I'm an obstetrician and gynecologist I work at University Teaching Hospital of Kigali, and I'm also a member of the PPH Community of Practice Steering Committee. So I think we have really had a very interesting first day of the PPH Committee of Practice annual meeting, and My task today is just to lead as someone who has followed together with all of you as a participant, just to share with you some of the take-home message from day one. And I also want to highlight that this is not the end of day one, because after this summary, we are going to have the opportunity, in fact, to have a network hour, which is going again to be very great for us as a participant to share the experience, to be able to know each other, and then also try to see how we can use the knowledge gained either today and also tomorrow as we plan to implement some of the learnings in our practice and our daily practice. So today, if I start immediately, day one of the PPH Community of Practice annual meeting started with a welcome remark and the introduction by the PPH co-chair, Cherry Evans, who really thanked all the participants and then talked about the main objective of this annual meeting. And this annual meeting, the highlight was really talking about the PPH roadmap, vision, and objectives. And then another important objective was to make sure that we are discussing about different cadres who have to collaborate to make sure that we are addressing the postpartum hemorrhage, and then be able to also elevate cadre experience in implementing PPH roadmap, and then learn about how we can manage PPH which is not responding to the first response, which is the refractory bleeding. So today we have covered some of the main objective, and two of the main of the objective of this annual meeting have been covered. And this is what we are going to really go through and see what are some of the important takeaway we can have. After getting the objective, we have really great welcome remarks and opening remarks by Deborah Amster, who is Senior Maternal and Newborn Health Advisor at USAID, and who really also highlighted the importance of really now highlighting the needed effort to stop to reduce the number of women dying of postpartum hemorrhage, and then commended the effort of PPH COP in reduction of maternal mortality due to PPH globally through this kind of discussion. Then we had also opening remarks by Susan Stahl, who also talked mainly about some of the positives, such as now the number of women giving birth in health facilities, which have increased over recent years in most of the in many countries, the availability of data which has improved, but also the fact that now we are having a PPH roadmap, which again is a kind of a very new commitment that shows us where we want to go, and give us too much hope that we can really stop women from dying of bleeding. So we immediately started with the main, the setting the stage of the PPH COP annual meeting, which was talking about the PPH roadmap. So some of us might have already heard about the roadmap. If there is anyone who did not heard about it before, I think this was an amazing presentation from WHO, Jonas, who really gave us the main reason why this PPH roadmap was needed as we talk about it. And one of the main reasons he highlighted was about maternal mortality having flattened over recent years. We know that we had MDG era where we celebrated really great achievement in the reduction of maternal mortality, but over the last 5-7 years, we've seen that really this reduction was not meeting the target we want if we wanted to achieve the SDGs in 2030. And with this, there was a need to create to bring another new initiative which has not been done before to make sure that we can reach the SDG targets. So this was the PPH roadmap, which focused on 4 main strategic areas. So if you look at them as they were highlighted, one of them was research. And as we know, research is really one of the area which help us to be able to to identify new evidence on the way we can either manage postpartum hemorrhage, but also the way we can implement or accelerate the implementation of different innovations. Then the other important strategic area, which was presented today as a big highlight of the PPH roadmap, was about normal standards. And this again was found as an issue because most of the cases in the maternal newborn community, especially for people who are in practice, they tend to use different guidelines and sometimes with contradicting recommendations. And this really leads to challenge, especially that in some countries there are some specific which also needs to be addressed. So again, this important strategic area was highlighted as one that the PPH roadmap is going to look at and then try to come out with one kind of single kind of guideline which is going to allow us all to really be able to be sure that we are practicing the same way. So another strategic area that was highlighted was the challenge related to implementations, because as you know, most of the time, even when the evidences come out, we know that the implementation really delayed to reach women who they need them. And this again leads to a lot of mortality and morbidity resulting from postpartum hemorrhage because we were not able to implement on time. So the other important area that will have been identified within the PPH roadmap was about advocacy, where they noticed that global but also local advocacy is highly needed to make sure that the awareness is highlighted, but also the implementation of the available evidence is reaching women at the right time. So he also presented some of the progress that have been already made, because as we said, the start was in 2023 through the PPH Summit, but now there are already some achievement, which is something that again is people who are concerned by the postpartum hemorrhage that we really like to hear. And one of them was, first of all, definitely we know that the PPH roadmap has been initiated, has been launched, but also some of the activities are already being put in place. The research have already started with regard to each strategic area. So some of the research priorities we know that have been achieved. Right now, we have some research related to early detection and treatment, and those have been identified as areas that have to be worked on. But also, we know that now we need to also do some priorities research on implementation, but also at the same time we need to implementation barriers and the facilitators, but also we need to look at some innovation, and there are some ongoing research. For example, if we one example being like the implementation of tranexamic acid, not only as the IV medication but also alternative routes. So all of those in fact are being highlighted in the PPH roadmap and are a very positive initiative that are going to help us being able to make some targeted achievement if we want to meet the SDG. So this presentation was followed by many questions, and all of the questions were around these strategic areas, which we were highlighted: research, standards, implementation, and advocacy. And then it shows that really the audience is much interested with about implementing the roadmap within their local community and their countries. So after this, after setting the stage, we had also another great presentation, another session where we talked about cadres involved in the PPH management. And we know that without teamwork, without collaboration, PPH cannot really be managed. And here we had a presentation from Prof. Jacqueline Ducre, who is chief midwife at ICM, and then talked about really like the role of midwife in managing postpartum hemorrhage. And he talked about the reason why this session was really very critical, which as an artist, like midwife are really integral part of management of postpartum hemorrhage. And then he talked about the scope of practice, but what an educated midwife is and what are the competencies that are needed. So some of the highlights, for example, included the role of midwife in prevention, in early detection, then immobilization of professional members, in the justice requesting investigation, in management of postpartum hemorrhage, for example, when there is need to manage PPH attorney, but if there is a tier or just if there is any need to arrange transfers. So again, it was really highlighted that countries need to really put all the possible effort to make sure that the optimization of the use of midwife is made. And then also the need to ensure availability of structures and now enabling environment in health system level to ensure that PPH are really integral parts, or just all the countries and all the pregnant women benefit from midwives. Also, this session was followed by a number of questions, multiple questions, which focused the importance of multidisciplinary teamwork the participant really came back on this, and the presenter also highlighted the need for this, but also professional framework implementation in different countries was also highlighted as needed. So the last session was also a very special session because this one highlighted the example of implementation of the PPH roadmap, and we're blessed to have two great presenters who shared the experience of two countries, one of Kenya and the other one is Congo Kinshasa. And from the presentation in Kenya, we had an experience of how, for example, two main interventions were pushed to reach out to women who need them more. And we had experience of hearing, for example, how heat-stable carbetocin and tranexamic acid were implemented in Kenya through the initiatives. So we learned the examples of how this can be done, because this is why you have presentations such as this one. We need to understand how we can do the same thing in our countries. And you have learned about the importance of advocacy, how, for example, if a new medication is out there, like tranexamic acid, we know that has been published as it has to be used now since 2018, but still now there are some places where women are not benefiting or just are not being treated with it. But we learned some steps of how in Kenya this was done, where it was put on essential list of medication, then how the national guideline was updated, how they made quantification and made sure that their medicine is available. And then they also at the same time define which facility level this drug has to be used. As we know, we can't say this is going to be used only in teaching hospital and then we forget the lower level health facility where most of women are in the need of different interventions. Then they did the scale up. So this was really a breathtaking experience, like seeing how this was approached in Kenya, and then even the cost of the drug, which sometimes is a context of not use some of the medications such as carbetocin comes, but they managed to even reduce the costs with the implementation. After the experience from Kenya, we had another amazing, different kind of experience from from Congo, where we had Dr. Socrates Chuma Biamungu from South Kivu province, talking about also how they really started to reduce the maternal mortality due to postpartum hemorrhage. And they shared with us the methodology which they used, first of all, by doing a kind of assessment to understand the really reason why women are dying because of postpartum hemorrhage. And what he shared with us are really similar to what we see also in most of other facilities and in most of other countries. And again, it was a very good learning opportunity. So he shared some factors they identified, such as inappropriate follow-up, delayed transfer, poor resuscitation, long medications when women are in health facilities, or just delayed administration of medication, but also the fact of not involving women in the management. So all of these are really some of the common factors that we see leading to maternal death due to PPH, while if you address them, we really can be able to reduce the number of women dying. So this was really great because after identifying the issue, they now proposed a solution such as training of healthcare providers in the emergency obstetric and neonatal care, because they noticed that there was lack of training, but it also started integrating family planning. We know with family planning that we can reduce maternal mortality. Then they also they start implementing mentorship, so that high-skilled providers can train even those who are either newly graduated or who are hard to reach areas. Then they also have future plans, like what Kenya has done. They really want to implement tranexamic acid and carbetocin, which is one of the gaps they have identified. So this is where the session of today has ended. But before I conclude, I really want to say that even tomorrow is going to be a continuation of today. And we're now going to do a deep discussion about now really like the implementation either at the facility or so that we lead all of the discussion we've done from the policy level, from the global level, can now reach women. So we are going to talk about the management of postpartum hemorrhage. We know about the early management, but sometimes we have refractory postpartum hemorrhage, which we want really to see, like what are the available options, what are the discussion, what are the controversy, or what do we really need to start practicing to bring in our facilities or in our countries. Then we also have the opportunity to hear some example from different countries which have already started or which have good practice that they want to share with other countries. And then the last session would just be about now research, what is going on. We'll talk about the motive, which most of you already know, how to really have an impact on reducing maternal mortality due to postpartum hemorrhage. But we look at the process evaluation. Then we look at some other important studies, such as like the implementation, the early detection of postpartum hemorrhage, such as use of plastic drapes. And then we'll also look at some studies in tranexamic acid. So as you can understand, really, tomorrow is also very exciting. And then we invite you to be a part of the session as well. So before I end my summary remarks, I wanted to say that we are going to have an amazing networking hour where, again, we are going to share the experience, and then our facilitator, Aurora, will just take us through this. So with this, I really want to thank everyone again, and thank you so much for being part of the sessions today. Thank you. Over.